Pre-test we will be sharing in just another 2 to 3 minutes. The link will be shared in the chat box. Yeah, Richa, please.
Okay, we'll start. A very good evening and a warm welcome to everybody. Now today is the third day or the last day of the online FOGSI ICOG certificate course, which is on MTP, abortions and litigations. So for this, I am thankful to FOGSI and thankful to ICOG and Dr. Lakshmi Shikhande Madam and Dr. Parag Piniwale sir for giving my committee, that is MTP committee, this opportunity to conduct the certificate course. So now I invite the ICOG chairperson, Dr. Lakshmi Shikhande Madam, to say a few words and then we'll proceed for the pre-test. Yes, Madam.
Yes, very good evening, one and all. Today is the third day and the concluding day for this FOGSI ICOG online certificate course on MTP, abortions and litigations. And I'm so happy with all the interactions from the delegates to the faculties. And that is why we are having these courses on Zoom meeting platform, so that you all can interact with the faculties, and which I am really happy. Each and every speaker is getting so many questions after their talk, and it is so nice on part of all the speakers that because we are shortage of time, they are answering all the queries in the chat box. So today also I will be requesting all the speakers to please answer all the queries in the chat box. Friends, today also we will be having pre-test, but pre-test does not have any scoring. It does not have anything related to your certification, to just chill. Post-test, yes, of course, you have to score 50% marks so that you are eligible to get a certificate. But don't bother about pre-test and please focus on the ongoing talks, because last 2 days everyone is writing that we have not got this certificate, we want this, we have missed pre-test, please post link again. These are teaching courses, learning courses, so learn as much as possible. So without wasting much time, on behalf of ICOG, I take this opportunity to acknowledge the efforts by convener Dr. Richa Sharma along with her co-conveners, and I also welcome all the speakers, chairpersons and experts for day 3 module. So happy learning, and back to Richa for further proceedings.
Okay, thank you, Madam. So now can we have the pre-test link? And then I will be summarizing in day 1 and day 2 what all topics we had covered.
So pre-test link will be posted in the chat box. Please pay attention to your chat box. Mitali, link post karo.
Yes, ma'am.
She will be posting the link in the chat box, and then she will start the timer. Time given to you all is 10 minutes. After 10 minutes, the link will expire and you will not be able to submit your pre-test form. So just pay attention to the time also. She has shared the link in the chat box. Just have a look and start giving your pre-test. Meantime, we all will stop talking, so there won't be any audio, so that you all can focus on your pre-test. 1 minute left. Radha, but even then, so many delegates have submitted. I was going to tell Richa, have you made very easy? It seems pretest is very easy. It seems.
No, now they are used to, because first day they felt 10 minutes was very less. And then I think they are catching up the speed.
Yeah, they are catching up the speed.
Yeah, they learn the technique very fast.
I'm so happy that so many delegates have submitted pretest so fast today.
And that PCPNDT Act, no, it is very so many times we tell. So the answering is very easy today.
Good. So time up. Now you will not be able to submit your pretest form. So now Richa, please start our scientific session. Yeah.
A very good evening and warm welcome to all of you once again. So today is our third day and the last day of the certificate course. So I will just quickly revise what all we did on first day and second day. So first day, that was on 27th April, we mainly touched upon the acts, that was MTP Act and amendments. Then we spoke about FOGSO Act, PNDT Act, and then counseling pre-MTP and post-MTP, various methodologies, drug protocols, and then surgical abortion techniques. And this was on day one. And yesterday, basically, we focused on the abortion part. That was ectopic pregnancy, which we included a cervical, tubal, and scar ectopic. And then also complications and management of MTP. And then consent taking, the valid consent taking in various special groups also we had discussed. And the main idea of discussing all those abortion was that we clearly want to give you one important message, is that all these abortions, ectopic pregnancy, incomplete abortion, missed abortion, they don't come under MTP Act. So you don't have to fill the MTP forms for all these things. That is one thing. And secondly, ultrasound. Now it is always better to do the ultrasound in the previous scarred uterus, because the way scar ectopic pregnancy, the cases are coming. But other cases, you have to correlate clinically. Now, today we are mainly focusing on the litigation part. And so first we will start with a brief about post-abortion contraception, and then we will go to the various litigations like mob violence, intimate partner violence, and then death on table, how to deal with it, and then various offenses and punishments which are associated with MTP Act, FOGSO Act, and PCPNDT Act. Then very important panel on litigations in MTP, it will be discussed, wherein I think most of the queries will be answered. And then the safe kit and the examination of the rape victim also will be touched. And then how to dispose the fetus or the product of conception. And then last will be the few challenging cases which we have encountered in the practice. So these are the things which we'll be covering today. And again, we have eminent faculty, chairpersons, speakers, and the experts who will be giving the informative deliberations. So now quickly we move on to our scientific session. And for this, I will invite the chairpersons of this session. Can you share the slides, Dr. Anuradha?
Yes.
So our first chairperson is Dr.
Dr. Biswajyoti has also logged.
Okay, Dr. Madhuri Patil, she is the governing council member. Then Dr. Biswajyoti Guha, he is the senior consultant at Amri Hospital, Mukundpur, and also the secretary of Bengal Obs and Gynae Society. And then Dr. Kiran Chandna, she is the president of Faridabad Obs and Gynae Society and also the member of MTP committee. So we welcome you. And I request Dr. Kiran Chandna to introduce the first speaker, Dr. Vidya Thobi, who will be speaking on post-abortion contraception.
Good afternoon, and I'm happy to be part of this webinar. And I invite Dr. Vidya Thobi ma'am for her talk on post-abortion contraception. Dr. Vidya Thobi is president of Karnataka Society of Obs and Gynaecology. She is professor and head of department at Al-Amin Medical College, Vijaypur. Welcome, ma'am, Dr. Vidya. Dr. Vidya, ma'am, welcome.
Yeah. Please stop sharing so that I can share my screen.
Richa, you can tell
Mitali.
speakers only to share so that their first slide is CV slide. That will save a lot of time.
Yeah.
Chairpersons can read from that CV slide. Yeah.
Hope my screen is visible to everyone.
Yes.
Yes, ma'am.
So at the outset, I must congratulate ICOG chair, Dr. Lakshmi Shrikande. She's a very dynamic and so beautifully she has chosen the topics that the maximum attendance is for this certification course, and everybody wants this certification course to happen again and again, and so many things are asked in the chat box also. So thank you, Lakshmi, for again inviting me, and Dr. Richa, who has done so much crafting of this module. Congratulations, Richa, and I thank all the FOGSI office bearers. So I will be talking on post-abortion contraception. We all know about the statistics. I will not go again and again about these statistics. What I want to say is majority of these women who undergo this abortion, they don't want to become pregnant again in the near future. Yes, and WHO also recommends at least spacing of at least 6 months before abortion and next pregnancy. So it is our responsibility to provide the family planning services as a part of post-abortion care, which can improve the contraceptive acceptance and help to break the cycle of repeated unwanted pregnancy. So contraceptives should be used at every conceivable occasion. That's what the Spike Milligan says. And as Dr. Richa has mentioned, there are so many WHO guidelines and the books are available at the net. I want to say that everybody should save this and they can refer as and when. So all guidelines have the, mainly the 3 key areas. That is a pre-abortion care, abortion care methods, and these are repeatedly for last 2 days they have been explained vastly. What we want to focus is
moving.
Vidya, your slides are not moving.
Acha. I don't know whether I have sent to the technical person. So whether
तुम share करोगे इनकी slide, Jignesh?
Please.
Jignesh,
I'll stop sharing.
Ma'am, एक second.
तुम slide share करो और थोड़ा alert रहना, वो जैसे next बोलेंगे next.
I will not tell next only. You can just move on the slides. That will be better.
But they are non-medical, so you will have to say.
I'll stop sharing.
Yeah, you have already stopped.
I don't know.
Then there is some technical problem. Mitali, share करो.
This happened the last time also. That's why I shared the beforehand only.
Ma'am, 2 seconds. Correct.
And मेरा presentation बिल्कुल ही short है, so I will finish it in time. That assurance I give to Richa.
Great. Slide show करते मिताली. Mitali?
Is it okay, ma'am?
Yeah. You can make it slideshow. I have already done till that slide number 5.
Okay.
Slide show कर और slide देखो 3-4 cover कर ली है उन्होंने यहाँ.
Slide show.
Slide
हो रहा है मैम?
नहीं हो रही.
नहीं हो रहा है.
मैम हमारे यहाँ तो हो रहा है, 1 सेकंड में.
नहीं, ये इस पे नहीं हो रहा है.
Anyway, you can keep like this and then I can talk. No,
not is all right.
Now it is there.
Now it is moving, I think.
Okay,
Yeah.
is this slide?
Yeah.
so it is not a slideshow, but I can talk on that.
Okay,
I
ma'am.
was talking about the what Spike Milligan was talking about the contraception, and contraception should be used at every conceivable occasion. So these are the various books which are available at the net and you can refer as and when. But I just want your attention towards the safe abortion care and the post-abortion contraception here. The next slide, as I go on speaking, please change the slides. All guidelines have got 3 key areas in the management. So pre-abortion care methods, and aftercare and follow-up, including post-abortion and contraception and counseling. So every time the patient comes, she comes to for you for the abortion, you have to discuss something about the contraceptive options which are available. And whenever talk of follow-up, next slide, please. The follow-up care, we have to assess the woman's recovery after abortion, ask for any signs and symptoms of ongoing pregnancy if they are there, review any available medical records and referral documents, ask about any symptoms experienced since the procedure, and perform focused physical examination for any complaints, and focus on the woman's fertility goals and need for the contraceptive services if not provided earlier. Now, always help the patient to choose the right method. So what about the counseling? Counseling is an integral part of your practice, I must say, and it helps to understand the essential concepts of contraception planning, options for the contraceptive methods, and then choose a method based on her needs and preferences. That is the next slide. You have to choose a method based on her needs and preferences, timing of counseling, and assess individual situation, information on various methods, and method-specific counseling. These are the integral part of counseling of post-abortion contraception. Next slide, please. Then counsel the woman for informed choice before she leaves the health facility. If she chooses any contraceptive method, help her to initiate a family planning method of her choice. And if she's not able to decide on any family planning method, not eligible for any methods, then you have to schedule for follow-up within 2 weeks or give her a referral appointment in a nearby family planning facility. Additionally, you must remember that take her contact number and send a reminder message within 2 weeks. This is very important. Now, one has to focus on and tell the patients that when she has that return of fertility after abortion. So after first trimester abortion, after vacuum aspiration, woman may ovulate within 10 days of abortion and can become pregnant if she resumes sexual intercourse without using any contraception. Secondly, after medical abortion with mifepristone and misoprostol, on an average, a woman will ovulate within 20 days of medical abortion with mife and miso, but can ovulate as early as 8 days. Second trimester abortion, after medical abortion with mife and miso within 4 weeks after second trimester abortion or miscarriage. Next slide, please. So these should be our focused post-abortion key messages. These are the counseling messages. So either ask the patient to wait 6 months before trying to conceive again, as it reduces the chances of low birth weight babies, premature birth, and maternal anemia. And the fertility returns within 10 to 11 days after first trimester abortion or miscarriage, or within 4 weeks after second trimester abortion or miscarriage. So she has to choose from whatever available family planning methods that can be started at once. So always we give the cafeteria approach. If she decide not to use contraceptives at this time, then again, you have to offer the information on all available methods and from where to obtain them. That also is very important. So also you have to give the information about the condoms, oral contraceptives, injections, emergency contraceptive pills for women to take home and use later. So she should not have intercourse until the bleeding stops to avoid any infection. So criteria which are laid down in WHO medical eligibility criteria, that is MEC wheel, for contraceptive use should be adhered to. Next slide, please. So what are the choices of post-abortal contraception? So as I told about the medical eligibility criteria, that states the use of COC, that is combined hormonal contraceptives or progestin-only pills, and may be initiated immediately after abortion. And post-abortion, you can initiate one of these contraceptive methods. And that can be started on the same day as the misoprostol is used for medical abortion, or on the day of surgery in case of surgical abortion, or on the day of discharge from the hospital following the treatment of incomplete or spontaneous abortion. Implants are routinely inserted immediately after first trimester surgical abortion. Next slide, please. So this is the just in a tabular form, the time of initiation of contraceptive methods. So spontaneous abortion or vacuum aspiration, if it is done for incomplete or induced abortion, you can initiate combined oral contraceptive pills, progestin only pills, Sencroman pills, injection DMPA. Immediately you can start. Condoms can be started immediately by the male partner when they initiate their sexual intercourse. IUCD can be inserted immediately when the infection and injury to the genital tract are ruled out or resolved. Female sterilization can be performed concurrently or within 7 days post-abortion, provided woman is eligible for mini-lap as well as laparoscopic methods. About after medical abortion with mifepristone and misoprostol, combined oral contraceptive pills can be started on day 3 or day 15 of medical abortion protocol, as long as there are no medical contraindication. About injection, this Zencroman and progestin only pills can be started immediately on the 3rd day. Injection DMPA can be started on the 3rd day of the medical abortion protocol. Condoms, of course, I have already stated that it can be used by male partner as soon as the sexual activity is resumed. IUCD can be inserted once the abortion is complete, that is around day 15, and the presence of again infection is ruled out. Next slide, please. So this is the same. This is the same in a pictorial form, so I will not repeat. This is just a summary, and next 2 slides are just a summary of what I have told. So next slide, please. Yes. So after spontaneous abortion or dilatation and evacuation, again, this combined oral contraceptive pills, progestin only pills, and Sencroman pills, injection DMPA can be immediately started. Condoms from the male partner, and IUCD can be inserted immediately. Infection injury to be ruled out, and it should be specially, the insertion should be done by specially trained provider as per the postpartum IUCD insertion techniques. Now, female sterilization can be performed concurrently or within 7 days post-abortion, and it should be uncomplicated abortion. And if she has made a voluntary informed choice in advance. So in case the woman is eligible for the sterilization or mini-lap, then you have to just look into that laparoscopic tubal occlusion is contraindicated as there are chance of injury to the fallopian tube or uterus if tubes are edematous, and there is also possibility of slipping of these rings from which are the edematous tubes. So you should be cautious. So you can call the patient later. In these patients, these are the things which are available. Next slide, please. Combined oral contraception pills. Next slide, please. DMPA injectables, then condoms. Next slide. And the intrauterine devices. Next slide, please. So these are the things, just pictorial. I have made little, means people should not feel sleepy, so that I have to put the pictures, but everybody should know that these are the options available. Next slide, please. So about the intrauterine contraceptive device, which we insert following the first trimester abortion, one thing is there should not be infection or any injury. Even after second trimester abortion also, we can insert this IUCD, but again, you have to take precaution that there is no evidence or any infection, bleeding, or any other contraindication. So it is from the MEC, that is eligibility criteria 1 and 2. The clinical assessment and screening of the client assessment for immediate post-abortion IUCD is done in 2 phases. One is, first is review the woman's general medical and reproductive contraceptive and obstetric history and eligibility for the method along with the pre-procedure assessment. Second assessment is done immediately prior to insertion. That is, you have to rule out whenever you are going to insert, any infection is there, any risk of infection is there, any hemorrhage or any genital tract injury is there. So 2 steps you should take whenever you are inserting IUCD. Next slide, please. Now about the technique. Technique is, after surgical evacuation, the uterus size is below 12 weeks. interval insertion technique, that is no touch withdrawal technique with little adaptation. After surgical evacuation, when uterine size is about 12 weeks, the technique is same as postpartum IUCD insertion with little modification. And after abortion, medical abortion, the before the woman leaves the health facility, post-abortion follow-up within 1 or 2 weeks. The assessment, again, I have already told about this, that you have to rule out continuing pregnancy, sepsis, and incomplete abortion, any problem with the IUCD, and come for the routine follow for the IUCD checkup after 1 month, preferably after next menstrual bleeding, and immediately if any warning signs appear, if there is a bleeding, lower abdominal pain, any pelvic infection signs. And follow-up care and management of problems of IUCD will be the same as that of interval IUCD. What is important is 2 minutes only. What is important is a backup method which is not needed if IUCD is inserted within 12 days after first or second trimester spontaneous or induced abortion when there is no infection. If it is more than 12 days after first or second trimester spontaneous or induced abortion, no infection is present, and IUCD has been inserted after it has been reasonably ascertained that the woman was not pregnant. If infection is present, treat it, refer to the referral center, and help the woman to choose another method if she still wants an IUCD, or it can be inserted after infection has completely resolved. If insertion is delayed, a backup method is needed. Now, these are the various studies and RCTs, immediate versus delayed insertion. Immediate, if you insert immediately, the insertion of intrauterine device immediately after medical abortion, like 17 to 20 weeks, is more effective compared to delayed insertion. But they have found out that the expulsion rate is higher. The post-abortal sterilization. One is you have to confirm that patient has received counseling and she has made the informed choice, and the procedure should be performed only by the trained person, and it can be performed through mini lab or laparoscopy. Mini lab procedure only in second trimester abortion, because as I have already explained that the tubes are edematous. Laparoscopy can be done at a delayed period. Now, what are the eligibility criteria in case of female sterilization after abortion? So, uncomplicated, that is category A, except there is no reason to deny sterilization to a person with this condition. Post-abortal sepsis or fever, it is D. That is, procedure has to be delayed until the condition is evaluated and is corrected. If there is a post-abortal hemorrhage, again it is D. Severe trauma to the genital tract and cervical and vaginal tears are there, D. And if there is a uterine perforation, it is yes, that is a special. The procedure should be undertaken in a setting with the experienced surgeon and staff. Equipment is needed to provide general anesthesia, another backup of medical support like surgeon. If there is an acute hematometra, it is D. You have to delay the procedure until the condition is evaluated or corrected. So steps, I will not go into the steps post-abortion female sterilization. We all know. Next slide. So these are the various steps. 1, 2, 3, 4, 5, 6, 7, 8. That is till you get the certificate of sterilization. You have to go further, Mitali. I have already covered. Yeah. Next slide, please. Next slide, please. Eligibility criteria I have covered. Yes. Next slide, please. Previous one, the other methods of contraception. So these are the other methods of contraceptions like combined oral contraceptive pills, progestin-only pills, Send-Croman, injection DMPA, condoms, and male sterilization can be started immediately. We have to counsel the male partner. Mentioned in earlier, after appropriate method of specific counseling. If the woman is starting OC pills, progesterone-only pills, Send-Croman, or injection DMPA, within 7 days after first or second trimester miscarriage or induced abortion, there is no need for any backup method. Then if it is more than 7 days after first and second trimester miscarriage or induced abortion, she can start these OCP and POP anytime if it is reasonably certain that she is not pregnant. But she will require a backup method for first 7 days for OCP or injection DMPA or Centroman, or for the first 2 days in case of progesterone only pills. So this is just, next slide please. So this is in nutshell overview of post-abortion family planning. We all know the time of administration I have already discussed. The advantages we all know about the OC pills. It can be started immediately. Even if infection is present, you can start OC pills. It can be provided by non-physicians and does not interfere with any intercourse. So these are the advantages of OC pills. Progesterone only pills or DMPA or injections, they're highly effective, can be started immediately. Even if the infection present again, it can be given by non-physicians, does not interfere with the intercourse, non-user dependent, except for remembering to come for injection every 2 to 3 months. No supplies is needed by the users. But only thing is, what worries us is it may cause irregular bleeding, especially amenorrhea. Excessive bleeding may occur in rare instances, delayed return to fertility after stopping the use, and must receive injection every 2 to 3 months. Next slide, please. And intrauterine devices we have already discussed in length. So they are highly effective. Immediate return of fertility. This is very important following removal. Does not interfere with intercourse again, and but only requires only once monthly checkup. You have to tell the patients, you have to teach her about the checking of the strings by the user, and only one follow-up can be used, can be had. But only thing is it requires the expertise, and it may increase the menstrual bleeding, cramps, increases inflammatory infections, and it may hamper sometimes subsequent infertility. And these women are at risk of sexually transmitted diseases. So trained provider is very much required for copper T insertion or any uterine device insertions. About the tubal ligation, we have discussed that it is a permanent method, highly effective. Once completed, no further action is required, and no long-term side effects, and it is immediately effective. The adequate counseling is very, very important. So counseling part is very integral part of any comprehensive abortion care. So this is very important. Condoms, you have to ask them proper use, and they sometimes cause itching for few people, and there's a small possibility that condom will slip off or break during sex, and then again patients can come for your follow-up. They come for pregnancy and termination again. So at the end, I must say that family planning counseling is very integral part, and provision of effective, last slide. Next slide, please. And effective contraceptive methods should be an integral part of post-abortion care. So improved obstetric services and child spacing will reduce the maternal morbidity and mortality in developing countries and developed worlds. So contraception should become people's movement rather than be forced upon the people. And people should insist on good quality, affordable contraceptive services as their basic right. So respectful abortion care was a thing which last president of FOGSI, they introduced, and we talked about it. So in India, next slide. Next slide. Yes. So in India, abortion is legal. Let us make it safe and respectful. So Samartha Bharat and Sampurna Bharat, that's what we say. But for every woman who steps for abortion in your clinic, you have to talk about contraception. You have to provide all the contraceptive methods, and whatever she accepts, you have to provide it. Thank you very much for patient hearing. Thank you, Richa, again for calling me and inviting me for this topic. Thank you very much.
Thank you, Dr. Vidya, madam. It was very comprehensive talk. And I think you finished on time also. So thank you so much.
Thank you, Lakshmi, also. She has given so many opportunities, and this was a very important topic for me also to talk again. Thank you very much. Thank you, Lakshmi.
There are 1 or 2 questions in the chat box, Dr. Vidya.
I will answer them.
Yeah,
No
yeah.
problem.
Okay. Thank you. Thank you. Dr. Anuradha, over to you. You have
I
to
will
unmute
answer in the
yourself.
chat box only. Yes.
Unmute
Hi.
yourself. Yeah.
Yes. Dr. Vidya, now we go to the next talk, which is Death on Table by Dr. Dilip Walke. I request Dr. Biswajit Goha to introduce the next speaker.
Good evening. Thank you, Dr. Srikande, for making me a part of your unique program today. And it's my proud privilege to call upon Dr. Dilip Walke. Can I have his CV on the screen, please? Dr. Dilip Walke is a consultant at Jupiter Hospital and Medipoint Hospital, Pune. He is a chairman, Ethics and Medical Legal Committee FOGSI from 2007 to 2010, and President POGS from 2019 to 2020. And he is also the co-author of Uniform FOGSI Concepts. And he is going to speak on death on table. So over to you, Dr. Walke, please.
Thank you very much. Am I audible and can you see me?
Yes, yes.
Yeah. So if somebody can give me the.
We can't see your screen.
Anyway, the slide sharing I have not started yet. So am I permitted to share my slides?
Yes, please. Yes.
Can you see my slides?
Yes.
Yes, sir.
We can.
Just a moment.
Just put it on a slideshow, please.
Okay, I'll do that. Just a moment. Can it be seen?
No, it's not on slide, so it's still, yeah, now it's.
Yes.
It is?
Yes.
And when it goes to the next slide, is it going?
It's gone to the last slide, so please come back again.
Yeah, no. Thanks is my first slide.
Oh, you have got that.
I usually thank all my
Thank
friends
you,
before
thank
I
you.
actually start. I mean, thanks to Lakshmi, especially. It's been a long time, Lakshmi, since we have met. It's so unfortunate that we are meeting only on Zoom.
Yes.
There has to be some reason now to meet in person.
Yes.
And also thanks to Richa for having given me this opportunity here to speak. When I say that today I'm going to talk on death on table, it is indeed an irony, because on 6th of this month, I almost died on table when I underwent a very weird surgical emergency. I had to go in the ICU. I had to be on a ventilator. I had to go through a dialysis. Parag, Kiran Kurtakoti, Dr. Gupte, they were all alongside me. So when I got this topic, I asked Parag, does ICOG want me to speak on that experience of mine? So Parag said, no, Dilip, forget that as a bad dream and get set for Dilip 2.0 life ahead. And that's what I'm doing. I'm getting back to the groove and starting my first presentation after that weird surgery and that experience in the ICU that I went through. So I have not timed my presentation today. So if I am going out of the time limit, please stop me at whatever times, Lakshmi, you feel that I've spoken enough. So death on table, medical legal tips is the topic for my presentation today. So what I thought was, let's enact a drama. This is what I usually do whenever I speak on this topic. Let's see that suppose that we have a 5-bedded small nursing home and you're trying to do an LSCS or you're conducting a normal delivery and there is a postpartum hemorrhage and then there is a cardiac arrest and a near death situation that you're going through. And then how do you manage that? This is the way we will go along in this today's presentation. Now, the foremost issue is that whenever you are facing a problem like a postpartum hemorrhage, the problem is we have never spoken about the possibility of a postpartum hemorrhage to our patients. Because that's the reason why patients say, Doctor Sahab, aapne to bola tha ki sab kuch theek hai. Ye achanak peach kaise hua? Actually, what they are secretly discussing amongst themselves, कि कुछ तो गड़बड़ डॉक्टर ने किया है. So this narrative that सब कुछ normally होने वाला has to change. And how do we change this narrative is what FOGSI has recommended in the uniform FOGSI content, wherein we are also talking about consents for natural vaginal deliveries. And that is done in two parts. One is information, wherein the patient gives a signature about the information. I want you all to go on the FOGSI website, download this and read the information that we have given about normal delivery and how we have dealt with all the possible complications. And then there is an undertaking which the patient gives on two occasions. One is during the antenatal period, and second is when she comes in labor. And of course, despite this consent, we have to take specific consents like consent for LSCS, MRP, etc. So these are all the points that we have covered in the information part of the natural vaginal birth. So I want you all to go on the website, read that, and if you feel that there is something else to be added, and if you feel that there's something to be edited, this is not a final consent. We can keep on editing, keep on adding, deleting whatever points that you may tell us, myself, Dr. MC Patel, or Dr. Nikhil Datar, who were together involved in making this FOGSI uniform consent. So never give any chance to the patient or the relative to say, "Hame kuch nahi bataya tha." Now, having diffused this allegation, the next job is to diffuse the challenging situation of possible maternal mortality smartly. So tip number one is do not panic, because death on table or death in the labor ward does not always mean negligence. The court will try to find out who managed the labor. The court will try to find out were the doctors qualified to conduct the delivery and give anesthesia and operate, and did they act in a way that an averagely skilled gynecologist would have done in that situation. So the court doesn't expect you to be somebody like a Lakshmi Srikande or Dr. Vidya Thobi to manage every labor in a very skilled manner. All that the court wants to know is, did you act in a very averagely skilled manner, and did you give a proper reasonable care? Tip number two is relax and resuscitate, because that is the first thing that you have to do. And when you are resuscitating, who should resuscitate? The anesthetist. If the anesthetist is available, let him take charge, because he's the one who is properly trained in the advanced life support, and he's the one who's properly trained in intubation. So he or she should be the person who should take charge whenever there is a problem. Equipments and drugs for resuscitation. Initially, Lakshmi would know that whenever we went all around FOGSI giving talks about medico-legal aspect, we used to tell that every small nursing home needs to have a boils and a defibrillator. Now I go one step further and I say, even if it is a small nursing home, if you're going to do laparoscopic surgeries there, you need to have an anesthesia workstation also with CO2 absorber and capnometer. So you have to upgrade your nursing homes. You have to have proper equipments for resuscitation. We, like the corporate hospitals, have crash cards with them. We can have small emergency trays which has got everything like IV fluids, IV set, blood sets, intracat, syringes, needles, emergency injections, everything, even sticking plasters, ampule cutters, everything should be there in that emergency set. So what you need to do is just ask sister, get that tray. And once she gets the tray, you should be able to handle the situation. The last thing that I've mentioned here is laryngeal mask, because when I was the president of Pune Society in 1920, one stall I used to always keep outside the operation theater, because my wife is an anesthetist. She used to stand there on the stall and we had a mannequin. Everybody had to put in a laryngeal mask inside the mannequin and only then enter the auditorium for the lecture or for the session. And everyone, let me tell you, everyone who attended all my conferences during my president's tenure, everyone brought one LMA. And I can tell you 2 cases in Pune and the Pune district who were saved because the gynecologist actually put in the LMA till the anesthetist was called in emergencies like the ones we sometimes face in our practice. Document your resuscitation well. Good document is good defense, bad is a bad defense, and no document is no defense. This is what medico-legal experts always tell you. But when you're in that situation, sometimes you're very so afraid and you tend to make mistakes even while documenting. So what I suggest is you have printed and laminated protocols for managing of cardiac arrest and anaphylaxis, laminated and pasted on the walls of your operation theater, and on the walls of your labor room, so that you can just make a copy and make notes and will not miss anything when you actually make your notes of cardiac arrest management. Of course, no expiry date drugs, because no sooner than there is a maternal death or death on table, the police officer will come, and the police officers only know two things. One is whether the oxygen was there in the oxygen cylinder, or whatever the drugs that were used, whether they were past expiry or not. So please check all the expiry date. In fact, this is Kiran Kurtakoti's idea, that he sees to it that the staff has checked all the expiry date of the drugs that are kept in the labor room and the OT before he actually gives them the payment of that month. So you can have your own idea of doing it, but see to it that the expiry date of drugs that are there in your operation theater and labor room are checked every time. No prescription of life-saving drugs. Never give prescription of drugs which are such that they are life-saving drugs, because I can tell you of a case in Pune wherein not of a drug, but the doctor had given a prescription of a pencil cell which she uses for the finger probe of the pulse oximeter. Now, this person is claiming in the court of law that the doctor did not even have a proper pulse oximeter, and how was it possible that he would have monitored my patient? And this is a patient of cardiac arrest post LSAs, and she is a vegetative patient at the moment in Pune. Last 5 years have passed now, and the case is lingering, and the doctor is in a soup because of this prescription that the doctor had given to the husband of the case. Then tip number 3 is call for help, rush stream concept cone. But the usual reaction to this is many of the seniors say, "Kaun is jamele mein padega," because the Good Samaritan law is still pending in our Lok Sabha. But though it will, one of these days, it will get passed in our parliament also. However, you have to remember that till such law is passed, even in our courts now, a Good Samaritan is made accountable only if that Good Samaritan who's come and helped the doctor has done something palpably wrong. So don't be afraid to rush when called, especially by the juniors, because he feels he is in a soup. It is your duty to go and help him out of it. Then what I'm saying is communicate with your staff. And you must be wondering that Dr. Valke is talking about communicate with your staff even before he's talking about communicate with the relatives. Because you know what happens whenever there is a problem like this, it is not the doctors to whom which the patients ask. The relatives would ask the Aya Maushi, Andar kya hua re? But they want to find what really happened. So call all your staff nurse, your Aya, your Metrani, your receptionist, and tell them what exactly happened and why it happened as per the defense that you're going to take in the court of law. So whenever they are asked about what happened, everybody will speak in the same language, and everybody, whatever they will speak would be in sync. So talk with your staff before you talk with the relative. Now, even if you're closing a dead patient, see that you will check the MOP count properly, because even if this dead patient later on goes for a postmortem and a MOP is found inside, unnecessarily, whatever good treatment you may have given to the patient, unnecessarily you will be in trouble because the MOP was found there. Now, shifting to the tertiary care hospital have to be done in two situations. One is after death, and second is before death. Now, after that, in the good old days, we used to advise that make sure that the patient is alive but serious and shift to an ICU and declare the death later on in the ICU, so that the possibility of mob violence is less. But today, in today's era where there are so many monitors being attached to the patient's body, I think this advice is no more true. You will have to declare death and say that the patient died in your theater if the patient died in your theater. So this advice no longer is true. But before death, when the patient is serious, I mean, I've tried to capture it in one slide, but it is quite a big topic, that you take a joint decision. All the treating physician, the surgeons, the gynecologists take a joint decision, shift a hemodynamically stable patient, which means not too early and not too late. Doctors or resident doctors trained in resuscitation should be accompanying the patient. So at least the person who's accompanying the patient should be trained in ACLS training. So that is so that you will be able to prove in the court of law that I did not shift the patient in a way that the patient would be not monitored and patient would not be taken care of while the patient was being shifted. Proper transfer note, closest center of the patient's or relative's choice. And if the choice is left to us, then closest center where you have rapport. Or if the patient is not affording, then to a government hospital, because government hospitals are not supposed to refuse any such patient. That is a Supreme Court judgment. Of course, consent for transfer, if you have time to take a consent for transfer, then you can take a consent for transfer. But if it is not there, then it's an emergency and you can even transfer without a consent. Then complete the paperwork, because paper should not be visibly manipulated, not too perfect, no omission of obvious step, no contradictory note, because I know of a case in Pune where the doctor was advised to defend the case of a postpartum hemorrhage as amniotic fluid embolism, but the physician notes mentioned a history of postpartum. So please, no contradictory note. If there is absence of consent and now that, don't take for thumb impression of a dead body there on the because the dead body could belong to somebody who was say MA in literature, which actually happened in Bandra in one of the cases in Bombay. So if you have not taken consent, say that you have not taken consent and do that. Because sometimes when we manipulate patient papers, we have a feeling that मैंने paper manipulate किया, अभी कुछ डरने की बात नहीं, because but the judges do understand that just as we are very proud, no, patient को देख के पता चलता है कि patient को appendicitis है, patient को देख के पता चलता है patient labor में है कि नहीं. वैसे one of the judges told me, doctor साहब आपका paper देख के पता चलता है whether it is manipulated or not. So manipulate, but then see to it that it will not be too perfect or too perfect a paper. Then set the OT in order before you allow anyone like a police or a relative. Now, this is something that I'm telling you off the dais, because actually, as per the legal requirement, you're not supposed to touch anything that is there in the OT, but you can, before the relatives or the police come, clean the floor of the blood stains, because no sooner than these police and the relatives come, even if there is a little blood on the floor, they say bucket bhar ke bleeding hua tha and things like that. So dispose the drape stain in blood. Check all the equipment, especially the oxygen cylinder, because the police is trained to see the oxygen cylinder. Check the IV lines, check the catheter, save all the used material, check the expiry of the drugs, and check the endotracheal tube. Now, initially when I used to talk on this point, I used to say, check whether the endotracheal tube is inside the trachea. But now I say it is better to remove the endotracheal and tube and keep it aside, because in one of the cases, again in Bombay, the dead body was shifted, and while the body was shifted, the endotracheal tube came out of the trachea and went inside the esophagus. So during the postmortem, it was reported that the tube was in the esophagus. So please, now my new advice is to remove the endotracheal tube aside and before the police comes. Now, informing the relatives about what happened, I always say, is a ceremony. It has to be a time-to-time information. You just cannot come out like the Hindi movies and come out and say, "Aapka patient bach nahi gaya." That is not the way it should be. You have to come out time to time and say that the patient is serious. We are doing what we can do. I've called this doctor. I've called that doctor. We are managing as a team and things like that. And this information has to be given by a senior with proper communication skill. And when I say you have to be polite, patient, and sympathetic, but assertive, it is easy, very easy for me to say all that in one sentence, but it takes a lot of time. It takes a lot of experience in your practice to become polite, patient, sympathetic, at the same time be assertive. So this you will learn as you become senior in your practice. No blame game. And the surgeon should not blame the anesthesia, say कि surgery तो सब ठीक चल रहा था, but suddenly blood pressure down हो गया, anesthesia में कुछ problem हो गया रहेगा. Yeah, anesthetist should not say that everything was okay, but खूब बहुत bleeding हो गया and फिर BP down हो गया. These things are not to be done, because you have to fight the case as a group. The moment you start your blame game, your case is lost. And you have to be, of course, prepared for mob frenzy, and there's going to be a talk on mob violence, and you will know how to do and how to tackle mob in that presentation. Now, before I end, there are 4 questions about maternal death, which I thought was very important from medico-legal point of view. The question number 1 is, should all maternal deaths be informed to police, or should all table deaths be informed to police? Point number 1. Second question is, who has the onus of asking a medico-legal PM? Is it you or the police? Third is, if cause of death is known, like in PPH, you know the cause of death. The patient died because of multi-organ failure, because of severe hypotension, because of post-hypertension, because of postpartum hemorrhage. You know the cause of death. Can I not give a death certificate? That is the question number 3. And can appropriate authority doing the death review, maternal death review, pull us up for not doing PM in a case of maternal death? So these are the 4 questions I thought was very important, and I've been asked this question many a time from all over the country. So I thought today I'll take an opportunity to answer those questions. The first thing is, there is no statutory law in our country which forces us to inform all death on table to the police. Because supposing there is a ASA grade 4 cardiac surgery happening and the patient dies on table, do you think they are going to inform such a death to the police? However, because our obstetric patients are young and are not expected to die during labor on LSCS or during a hysterectomy, and since we are going to be one of the accused party, it is better to call the police to investigate. There is no statutory requirement. So many a time, if you know the cause of death, if the patients and relatives are okay with it, you can give the cause of death. So this right you should know while you're calling the police. Definitely call if the mob violence is suspected. Man, there are many times I have got phone calls कि दिलीप अगर मैंने एक cause of death दिया नहीं तो mob violence होने वाला है. I tell them, तुझे क्या लगता है? What is the cause of death? He says, मुझे ये लगता है. Give it and see that the mob violence is averted. So this right you should know, that you have a right to give a death certificate if you are the treating surgeon. Even if you have done the surgery, even if the patient has died during your surgery, you have a right to give the cause of death. The police, when it comes, whether you have called or whether the relatives have called, it is the duty of the police to decide that this death certificate should not be accepted, and that the police is suspecting something, and it is the duty of the police to take the body away for medico-legal PM. So don't spend your energy in trying to convince the relatives कि नहीं body लेके जाना पड़ेगा, postmortem करना पड़ेगा. When the relative comes and asks you, you tell them मुझे cause of death पता है, मैं cause of death दे सकता हूँ. Let the police come and decide whether cause of death can be given. And if the police says they do, then they give the cause of death. Take it in writing. There was a time when we used to say that taking something in writing that we have got nothing against the doctor is not done and it will not stand in the court of law. No, it can stand in the court of law. You can take it in writing from the relative that we've got nothing against the doctor and we are ready for any cause of death. So that can prove in the court of law that the doctor knew the cause of death. The doctor gave the cause of death. The police found there was nothing suspicious. The relatives found there was nothing suspicious. So everything was managed. So this is the new advice that we medico-legal experts nowadays give. Now, can we give a decision? Yes, you can give a death certificate. But since our patients are young and not expected to die during surgery, cause of death given by a PM surgeon is going to be more relied upon by the judges than the cause of death given by you, because you are one of the accused. So it is better when you are sure that तुमने अंदर कुछ गोची किया नहीं है, then it is better to tell the police, अरे यार बॉडी को मेडिको लीगल पीएम के लिए भेज दो, मैं नहीं देता हूँ cause of death. अगर आप इंसिस्ट करते तो मैं दे दूंगा, लेकिन it is better कि बाद में तुझे भी तकलीफ नहीं होगी, मुझे भी तकलीफ नहीं होगी. Let the body go for a medico legal PM, because whatever cause of death is given by the PM surgeon, that is going to be taken as the last word in the court of law. And even if you're sending this body for medico-legal PM, in the note that you give to the PM surgeon, you can always mention that according to me, the patient have died because of this reason. Because then it will be a pressure on the PM surgeon to refute whatever you have written as a clinician. So that will put a little pressure on him, even if he is trying to act a little smart and give a cause of death which is going to put you in trouble. And can the appropriate authority pull us for not doing a postmortem? See, an appropriate authority doing maternal death review has got no authority to pull us up for alleged negligence. What they are doing is just making a review of a maternal death. In fact, at that time, you can talk about things like transport nahi tha, patient ko aane ko late ho gaya, patient anemic thi, government ने कुछ changes करने चाहिए. So you don't even think that appropriate authority is like a judge trying to find out whether you were negligent in the case or not. So this is, I thought, was very important. Then, however, how do we prepare ourselves for police and Panchanama? Give statements, give a number and signed copy of the completed indoor paper. If insisting before completion, sign under protest. Sometimes the police will insist, नहीं वो paper बाद में complete करो, जल्दी आओ, हमको अभी का अभी paper चाहिए. Then you can sign under protest, say that I am handing over this paper under protest and there is a lot that I have to yet write. So that when this paper goes in the court of law, the judge will say that, yeah, whatever you have written later on, you also submit that. Allow the body to be taken for MLC, PM or hand over the DC to the police. And then post, you have to know these sections. Post Jacob Matthews situation has changed because now there has to be an inquiry, there has to be a government or civil hospital committee, then an FIR report has to be there to say that there is prima facie evidence of criminal negligence, and only then under 304A you will have to be, you will be arrested. Then there will be a magisterial inquest and case in the consumer court. And I thought, this is the last slide. I thought everybody should know the difference between 304A and 304 Part 2, because many times the police are very mischievous and they arrest you under 304 Part 2. Actually, you should be arrested under 304A. Now, first of all, try to understand what is 304 Part 2. There are three things. One is conduct, knowledge, and intention. The typical Salman Khan case, conduct. Salman Khan ने दारू पी के गाड़ी चलाया. Yes, the conduct was there. सलमान खान को नॉलेज था कि दारू पी के गाड़ी चलाने से कुछ भी हो सकता है. Yeah, he is an adult. He knows that दारू पी के गाड़ी चलाने से accident हो सकता है. But did he have any intention to kill anyone on the footpath? He did not have an intention. So this is 304 Part 2, where maximum punishment is 10 years, with fine, which is non-bailable because he will have to be arrested, and for the bail he has to go to the magistrate on the next day, or if it is a Saturday, then on Monday. And the bail is given by the magistrate. So you may have to spend a night or two in the custody. Against that, 304A is rash and negligent act not amounting to culpable homicide. Again, conduct is there. Yes, you did the surgery and during surgery, something happened and the patient died. So the conduct is there. Was there any intention? No, you had no intention to kill the patient. Was there any knowledge? Now here is where there is a catch. We think that we had no knowledge that the patient would die, but the police says, "आप तो doctor हैं, आपको तो सब मालूम है, आपको मालूम है इससे patient मर सकता है," and they say that you have knowledge and they put you under 304 Part 2. But having knowledge and being knowledgeable about the anatomy and physiology of the body are two different things, and that is what the people like MC Patel, people like Gitendra Sharma, and all the all the medical legal committee people will help you to fight in case you are caught up in such a situation and booked under 304 Part 2, because we want you to be booked under, if at all, under 304 Part 2, because here the maximum punishment, if at all, is 2 years, and no doctor has been ever convicted under 304A also, the fine plus fine, and it is bailable, meaning the bail can be obtained from the police station itself, so you need not spend the night in the police station. So if you are booked under 304 Part 2, instead of 304A, then all you have to do is contact the Medical Legal Committee of FOGSI. You can contact me also. I'll help you in whatever way I can. Yours truly will be available on 98220-38583. Thank you very much for a patient listening.
Thank you, Dilip sir. Thank you so much for the informative talk. And sir, get well soon.
Yeah.
Our
Thank you so much,
wishes to
Richa.
you.
Thank you. Thank you so much.
Very well explained, Dilip. There are so many queries. Please answer in the chat box.
Yeah.
Before you leave.
Okay, I'll do that.
I must say it was an excellent talk, Dr. Walke. It was a
Thank
pleasure.
you. I mean, I've given a talk after, say, what, about 1.5 months. I suffered April.
Fantastic. So it was a very nice talk. Thank you very much.
Thank you.
On to the next lecture, which is on intimate partner violence by Dr. Neeraj Nagpal. And I request the chairpersons to introduce the next speaker, please.
Dr. Neeraj Nagpal is consultant physician and he is convener and managing trustee of Medical Gynaecological Action Group. He is ex-president IMA Chandigarh. He is director Hope Gastrointestinal Diagnostic Clinic, and he has written many books and given many lectures on the medical legal aspect. And we hope to listen from Dr. Neeraj Nagpal on intimate partner violence. Welcome, sir, for your talk. Dr. Neeraj, sir.
Yeah, he was here only. Dr.
Well, I'm
Nagpal.
still here.
Yeah.
Thank you so very much. I must thank the organizing committee for including me, but I was wondering why I was given this topic, because mostly I have given talks on things which are different, like even the death on table and the violence issues and the CPA and so on and so forth. But I must thank the organizers for actually giving me this topic, because it was an eye-opener. It was a learning experience for me also. And I did a survey of my own where I asked a couple of senior gynecologists in Chandigarh regarding intimate partner violence. When do you suspect? When? What do you do if you encounter? And to my surprise, the awareness and the acceptance that there is intimate partner violence among that we see in our patients is sadly lacking. This is something which really bothered me. When I'm looking at the data says that 1 in 3 women in India is likely to have been subjected to intimate partner violence. I know from my medical college days when I was doing my residency, one of the doctor couples, the husband killed the wife, put her in a gunny bag, transported to some fields, threw her there. So many. I mean, I know of cases where junior consultants in PGI, acid was thrown on her. So these are the kind of things we all come across in our career, but these are the extreme cases. What we need to understand is that violence takes many forms, and if we are not aware, we will not pick up. If we will not pick up, we will not do something about it. It is also very clear that only 1 in 10 of these women formally reports the offense. This is what is most bothersome. In this particular study, a total of 66,013 ever married women. It was not necessarily they were married, ever married, between the ages of 15 to 49 years were included, and lifetime prevalence was found to be 31%. Physical violence was accounting for 27.4% of the victims, followed by emotional in 12.7% and sexual violence in 6.7%. Higher women's age, Muslim religion, low education, employed women, lower socioeconomic status, presence of substance abuse among women and husbands, lower education and unemployed husbands, history of family violence, and women in central and eastern states had a significant association with 1 or more forms of spousal violence. These were all the things which indicated more violence happening. And spousal or intimate partner violence is one of the most common forms of domestic violence that we know. Domestic violence, as I will come to later in my talk, has multiple aspects to it. And it could be physical, psychological, sexual, economic, emotional, and it could be harmful in any of these ways in an intimate relationship. In the physical violence, there are 3 levels of intimate partner violence. Level 1 is abuse, pushing, shoving, grabbing, throwing objects to intimidate or causing damage to property and pets. Level 2 abuse is kicking, biting, slapping, and level 3 abuse is use of a weapon, choking, or attempt to strangulate. What is significant is marital violence acceptability is amongst the highest in the world in our country. 52% of all women and 42% of all men accept some degree of marital violence as normal. This is something which actually shocked me. Abused women commonly suffer from chronic gynecological problems, including chronic pelvic pain, sexually transmitted diseases, vaginal bleeding, and present very frequently to healthcare services and require a wide range of medical services. Other conditions affecting abused women include chronic pain such as back pain, headaches, neurological symptoms such as fainting and seizures, GI disorders, irritable bowel syndrome, very, very common. Half my patients have irritable bowel syndrome in women. We are using antidepressants right, left, and center, and we do not actually go into the detailed history of intimate partner violence. But after this lecture, probably I will start including as one of the questions I will be asking. Intimate partner violence is also a significant risk to pregnant women and their unborn children. And WHO recently reported a 2 times higher chance of having an abortion, miscarriage, premature birth, fetal injury, and low birth weight baby. And this is why this is a very, very important topic for ICOG to have taken up, and I applaud them for it. Apart from physical injuries, abused women have a lot of mental health problems like depression, anxiety, post-traumatic stress disorder, and substance abuse. Such women also suffer from low self-esteem and hopelessness, and these problems impact their ability to parent their children. So the next generation also gets affected. And why is there such a neglect on behalf of the obstetricians and gynecologists? The reasons we do not screen for intimate partner violence is there is lack of training. Yes, there is time constraints, discomfort with the role. We are not very comfortable asking intimate partner violence when the husband is sitting with the wife and coming for a consultation. There are misconceptions and misperceptions, and we feel powerless. This is also very true that given the social norms, given the circumstances, we actually feel powerless to do something about an issue which we may feel very strongly about. And why do women not report the violence? There is inability to recognize abusiveness. They try to find an excuse why the intimate partner was being violent. Cultural beliefs. They have accepted it because they have seen it in their parents, and it is an accepted part of their life. Fear, shame, feeling that abuse was deserved, something that she did herself. Blame, denial, hope, and financial worries. Most of these women from the lower socioeconomic status do not have an income of their own, and they are dependent on their husbands for their life, for their living expenses and everything. And so this comprises a major part of the reason why this is not reported. What are the clues which should increase the index of suspicion for us? Missed appointment. Somebody was to come on a particular date, does not come. There is a gap of 5-7 days. After that, the patient turns up. Have an index of suspicion on this. Repetitive psychosomatic symptoms, depression. Being accident prone, every time the patient comes, there is a mark somewhere in the body, and she claims that she fell down or she accidentally bumped into the stair or whatever. Substance abuse, poor reproductive history, vague and inconsistent description of injuries, delay in seeking attention for injuries, and partner's demeanor and behavior. The partner seems very aloof, very superior when he comes for consultation with his wife. And the patient's direct report of abuse, of course, is a straightforward clue that intimate partner violence has occurred. The demeanor of the woman during the history and physical examination can include a very flat or sad effect, especially if the partner is with her. Embarrassment on discovery of injuries, hesitance in discussing these issues, apprehension about discussing her injuries, evasiveness, and even anger if you question these people too much. And as I said earlier, this violence takes multiple forms, and it is physical, sexual, verbal, emotional, and economic. Harassment, harm, it does not necessarily mean injuries. Anything which endangers mental or physical well-being is part of intimate partner violence. So India had passed this act the Protection of Women from Domestic Violence Act. This was, sorry, something has happened here, 2005. And it has defined physical abuse, meaning any act or conduct causing bodily pain, harm, or danger to life, limb, or health, and includes assault, criminal intimidation, and criminal force. Sexual abuse includes any conduct of a sexual nature which abuses, humiliates, degrades, or otherwise violates the dignity of the woman, especially if it has been done against her will. Verbal and emotional abuse, which include insults, ridicule, humiliation, name calling, insults or ridicule, especially with regard to not having a male child, repeated threats to cause physical pain to a person who's aggrieved. Economic abuse. This is something which we all need to understand, that this is a reality in India, and this economic abuse includes deprivation of all or any economic or financial resource, including but not limited to household necessities of the aggrieved person. Disposal of household effects, any alienation of assets, whether movable or immovable, joint accounts being separated and made into a single person account, or selling off a property and which is held joint in a name, or is there is istri dhan, or in dowry the female has received something, alienating her from what she normally is expected to be having, the economically, is also economic abuse. Prohibition or restriction to continued access to resources and facilities which the aggrieved person is entitled to. Information to protection officer and exclusion of liability of informant. This is something which we should be clear, that if we are the people who believe that an act of domestic violence has occurred or is likely to be committed, the act says we may give information. It does not say you shall give information. It is may give information about it to the concerned protection officer. Now, who is a protection officer? I'll come later in the talk. And no liability, civil or criminal, shall be incurred by any person for giving such information in good faith. So if anybody, whether it is a protection officer, whether it is a medical officer, whether it is a police officer, whether it is a magistrate, anybody comes to know, he may give this information. And of medical facilities, the duty is to provide medical care to any such patient who is brought by the protection officer asked to treat the patient. The medical officer's duty, the medical facilities duty is to provide such care. In the act, there is no mention of who will reimburse the cost, but that is besides the point. It is a statutory requirement that you have to do this. There are many laws already in existence for punishment of domestic violence. You can use section 304B IPC. Dr. Valke just gave you an overview of that, especially relating to dowry death. This section 304A is used for medical negligence against doctors, but section 304B is relating to dowry death. Then section 313 to 316 of IPC, female infanticide, which implies forcefully ending the pregnancy of a woman. Other sections in Indian Penal Code dealing with these matters, like 305 to 306, related to abetment of suicide. 340, 349 for wrongful confinement and wrongful restraint. Section 498A for cruelty, which also comes under domestic violence. The problem is India has weird laws. I always say this. Why? A young boy of 18 years can adopt a child. He cannot get married till he is 21. He is 20. And here in India, Indian Penal Code had defined rape and had given an exception that one, medical procedures will not constitute rape, and two, that sexual intercourse by a man with his wife, if the wife was not under 15 years, is not rape. This section was changed by a Supreme Court order in 2017, and this age now has been raised to 18 years. So rape by a married man of his wife, if she is more than 18 years, is still not considered rape in our country. But from March 14, 2023, Supreme Court is now hearing petitions relating to criminalization of marital rape, and hopefully situation will change in the coming years. Police officers, service providers, magistrates who come to know of domestic violence shall inform the aggrieved person, the person who's the victim, of her right to make an application for obtaining one, either a protection order or monetary relief or custody order or residence order or a compensation or all of them or any combination of them. But this has to be told to the victim. Inform the lady of the availability of services of service providers, availability of services of protection officers, the right to free legal services under Legal Services Authority Act, and of a right to file a complaint under Section 498, that was cruelty, wherever relevant. Duties of shelter homes. Persons in charge of shelter homes will be providing shelter to such a lady who reports intimate partner violence. State government shall by notification appoint such number of protection officers. Mostly there are child welfare officers who are nominated, who are also notified to be the protection officers. Mostly, most of them are supposed to be women, but sometimes even men have been appointed at this position. Protection officers shall, as far as possible, be women and shall possess such qualifications and experience as may be prescribed. Now, once a protection officer comes to know that intimate partner violence has occurred, domestic incident has occurred, it is his duty to make a domestic incident report, give it to the magistrate, forward it to the police. It is not the duty of the victim. It is then his own duty to make an application claiming relief for issuance of a protection order. Then, to ensure legal aid under Legal Services Authority, maintain a list of service providers which provide legal aid, counseling, or shelter homes or medical facilities to such women. To make available safe shelter home, inform the police. To get the lady medically examined, ensure that an order of monetary relief. All this is the duty of the protection officer, and once contacted, the protection officer is contacted. So my suggestion is Google and find out who are the authorized protection officers in your area, and please have a list of their name, their mobile numbers posted in your clinics. This is the bare minimum we can do, and this is something we should all do. Who is a service provider? A service provider is any voluntary association or company registered under relevant acts with the objective of protecting the rights and interests of women by any lawful means. They may be providing legal aid, medical aid, financial assistance, or any other assistance, and shall register with the state government as service provider for the purposes of this act. Number of NGOs are listed. There are some government organizations also which are listed, but again, for each district, you will have to Google and find out who are the service providers who will be who are listed in your area. Record, they have the power to record the domestic incident report and do exactly what the protection officer can do. They can get the aggrieved person medically examined also. They also can get the aggrieved person into a shelter home. They can ask for protection suit under the act from the magistrate, and magistrate can order counseling with the victim and the husband both, or the victim or whoever is the perpetrator at any stage. The magistrate can offer this and order this. And if he has issued any such direction, the next date of hearing he has to provide within 2 months. The important thing is, the most crucial issue is, if a woman is complaining of domestic violence, she is thrown out of the house. It is very common. She is subjected to all kinds of threats, and even physically, she stops having a right in the shared household. This is a society we live in, especially in the rural or suburban areas. This is very, very common. So notwithstanding any other law, every woman in a domestic relationship shall have the right to reside in the shared household, whether or not she has any right, title, or beneficial interest in the same. What does this mean? She does not need to be a co-owner of the building. If she has been living in that shared household, just the fact that she has suffered domestic violence, purely because of that reason, she cannot be evicted. This is something which is very important to understand. Agreed person just cannot be evicted from this shared household if it is a shared household decided. The magistrate, after giving an opportunity of being heard, can pass a protection order. What is a protection order? Against the husband or whoever is the perpetrator of committing any act of domestic violence, aiding or abetting the commission of such domestic violence, entering the place of employment or school or any other place frequented by the victim, attempting to communicate in any form whatsoever with the victim, including personal, oral, written, electronic, or telephonic contact, alienating any assets, bank lockers, bank accounts, causing violence to dependents, other relatives, or any other person of the victim who comes to assist her in this domestic violence. The magistrate can also order restraining, dispossessing, or disturbing the possession of the wife from the shared household. This we have already discussed, directing the husband to remove himself from the shared household. In fact, the husband can be asked to move out, restraining the husband or any of his relatives from entering this portion where the wife resides, restraining the husband from alienating or disposing the shared household. They cannot sell the property and say we don't no longer own it. Restraining the husband from renouncing his rights in the shared household. If it is the father-in-law who's owning the property and husband says, Kiji, I renounce my rights, that does not mean the wife loses her rights to continue to stay there. The magistrate can also direct the husband to secure same level of alternate accommodation for the wife as was enjoyed by her in the shared household, or to pay rent for the same, provided that under no other clause shall be passed against any person who's a woman. That means the mother-in-law, the sister-in-law, these kind of clauses, they will have some kind of protection. Magistrate may require from the husband to execute a bond with or without sureties for preventing commission of domestic violence. The court may direct the police to give protection to the wife. Magistrate may impose obligations of paying rent and other payments, and ask the husband to return the istridhan or dowry which the wife may have brought. Monetary relief can be ordered to cover for loss of earnings, medical expenses, loss caused by destruction or damage or removal of property in control of the wife, maintenance for the wife as well as the children. Monetary relief should be adequate, fair, and consistent with the standard of living that the wife was accustomed to. Magistrate can also order lump sum payment or monthly payments. He shall inform the police regarding this monetary relief, and if the husband does not pay that, the police can take action. The respondent shall pay monetary relief within a period of a specified time, and failure to make payment, the magistrate may direct the employer of the husband to directly pay to the wife or deposit in court. The problem arises, what will happen to the children? So custody orders can also be passed under this act, and notwithstanding any other law, the magistrate may grant temporary custody of any child or children to the wife. If magistrate is of the opinion that it may be harmful to the interest of child or children, the husband may be refused any visitation rights. And compensation can also be ordered by the magistrate under this act. The penalty for breach of protection order shall be punishable with imprisonment of 1 year. So far, there was only monetary and the orders for protection. No punishment was there for the husband or the perpetrator of the violence. Now, the only punishment which the magistrate can order is if the husband refuses to abide by the protection order when there is a fine of 20,000 or imprisonment of 1 year or both. In addition, the magistrate can also frame charges for the section 498 and other sections of IPC as the case may be. The offence under subsection 1 of 31 shall be cognizable and non-bailable, even though it is only 1 year's jail for non-adherence to the order. Under section 31, if the magistrate has ordered 1 year jail, normally 1 year's jail does not become cognizable and non-bailable. But in this case, it is both cognizable as well as non-bailable. And upon sole testimony of the victim, nothing else is needed, the court will conclude that an offense has been committed by the accused. If any protection officer, this is important, fails or refuses to discharge his duties as directed by the magistrate, even he may be penalized by 1 year's jail or 20,000 fine or both. And I'll end my talk with a case law where father-in-law purchased a house in 1983, son married in 1995, started staying on first floor of the house, divorce filed in 2014. Wife, besides filing a divorce petition, also files a case under Domestic Violence Act. Now, father-in-law files a suit that I am a cardiac patient, I have suffered 2 heart attacks, and I have 2 stents, twice I have been stented. The daughter-in-law is threatening my wife, and she should be asked to vacate my house. So the trial court ordered the wife to hand over vacant possession to the father-in-law. Now, High Court, when this case went, said irrespective of the ownership of the premises, the daughter-in-law would still retain the right to reside therein as long as she is able to prove that she has endured domestic violence. Just because she claims and she can prove that there has been domestic violence, irrespective of who owns the premises, she has a right to continue to stay there. And Supreme Court, in a 3-judge bench hearing, upheld the decision of the High Court, asking the trial court to re-examine the whole issue. Thank you so very much. I hope I haven't overshot the time allotted.
Thank you, sir.
Thank you, Dr. Neeraj sir. It was very enlightening talk for us, and we learned new things. There are a few questions, sir. Please answer in the chat box.
I'll do that.
Thank you.
Yeah.
So now over to you, Dr. Anuradha.
Yeah, I request Dr. Gaurav Agrawal to speak on mob violence, which is the next topic. Dr. Biswajit, please introduce the speaker. I think already Dr. Gaurav's talk is on the screen.
So should I commence?
Yeah, please start.
Oh, thank you, Dr. Lakshmi, Dr. Richa, and office bearers of the ICOG FOGSI for this opportunity. So I guess on a lighter side, I think Dr. Neeraj Nagpal's topic has befallen upon me on violence. So anyway, just a little disclosure that I will not be speaking about factors responsible for violence, mob violence, or causes or prevention. My focus would be simply to focus only on the laws responsible for violence, because whenever we see cases of violence and we interact with the police and the doctors and the medical establishment people, what we find most commonly is that it is the wanton and gross, severe lack of knowledge, not only among police officers, that there are comprehensive and solid laws to protect medical establishment and doctors, but also there is lacking of similar knowledge with the medical establishment owners, with the with doctors as such. So my focus would be to talk about only the laws relating to mob violence. So to begin with, there is no codified law in India prohibiting mob violence or lynching in our country. And although this concept has been there for a long time, the Supreme Court has come very heavily on this concept, and it has mentioned in one of the judgments that a mobocracy is a horrendous act of mobocracy. It has tried to define mob lynching or mob violence. And to begin with, there have been few important case laws as defined by the Supreme Court, and some codified laws which directly benefit the life of an individual. And there is Article 21 on a person's right to life, that every person has a right to life and dignity. And if it is jeopardized, then it is a simple violation. It is a fundamental right. Then Section 223A of the Criminal Procedure Code says that whatever persons may be charged jointly, the following persons may be charged and tried together, namely persons accused of same offense committed in the same course or transaction. That means if there is more than two persons responsible for violence as a group against a particular, it is a general thing. It does not mean only a medical establishment. It could be anybody. Then those persons together could be charged for the same offense. Indirectly meaning when they're coming as a group or as a mob. Then there have been some important case laws decided by the Honorable Supreme Court, and one of the important ones has been Tehseen Poonawalla versus Union of India 2018, where the Supreme Court has said that Dalits who were under attack, they underlined some important measures that have to be taken by all the police stations across the country. And among them, it said that the state government shall nominate a police officer not below the rank of a superintendent police, and every district shall require appointment of a nodal officer to contain the menace of mob violence, assisted by a deputy superintendent of police, and a special task force has to be established to conduct reports on persons suspected of committing such crimes. The idea of sharing these case laws with all of you is that in case of an incident of mob violence, not only whatever codified law that I'm going to speak about in a moment, we can take help of these laws. So-called the Supreme Court judgment is a law in itself, and present it to the investigating authority and to the court. Court says that, okay, we often assume that the court is so intelligent and that they will use any law that is there to my benefit. It does not happen like that. The court says that there are thousands of laws. Whatever benefits you, you have to spell it out. Although in the prayer we always say whatever benefit the court can grant us, please do that. But it is we, the victim or the complainant, who has to spell out that under these laws we should be given benefit and the accused should be arrested or action taken against them. So similarly, there is Section 129 of the CRPC, which says that dispersal of assembly by use of civil force, a sub-inspector may command any unlawful assembly or any assembly of 5 or more persons likely to cause disturbance of the public peace or to disperse them. Similarly, there is Section 357A of the Criminal Procedure Code, which is meant to pay compensation by court to victims of injury, but that is then otherwise, it could be our patients, or it could be, any member of the mob that is affected, or even it could be the complainant that is affected, till such time the final judgment of the case comes in. Then in this Poonawalla case itself, the Supreme Court also said that the police fails to follow the guidelines, then it will be considered an act of disobedience on the part of the police officer, and negligent action must be taken against him. There is another important case law in the case of Nandini Sundar versus State of Chhattisgarh, where the Chhattisgarh government said that we will employ special protection officers and arm them. They'll be people from the armed janta to contain the menace of extremist myosists or to fight against the myosists. There is the case of Harun versus Union of India, where violence occurred, we are very familiar, 3 years ago in the district of Muzaffarnagar in the UP. And the Supreme Court said that any officer in charge of preserving peace and order in the state who is proven to be careless will be penalized according to the law, whether it is a police officer or a leader in a political party or anybody. Lastly, there is case law in the case of Archbishop Raphael Chinath versus State of Orissa. Again, it was a case of lynching of Swami Lakshman and Saraswati, where the Supreme Court came out heavily against the accused persons. So we often talk that, our Indian legal system does not have enough laws or the laws are weak. Yes, spiritually speaking, the laws made by men will always have some loophole. But, legally speaking, I say ours is one of the largest legal system on earth. And at the same time, it is one of the strongest as well. There are laws meant for almost everything, but we keep crying foul that there are not enough laws. So some of the laws that are commonly used in case of mob violence are Section 302 IPC, punishment for murder or death, 304 IPC, punishment for culpable homicide. Dr. Dilip just talked about it. Section 325 IPC, punishment for voluntary causing grievous hurt, imprisonment up to 7 years. Section 120B IPC, this is one of the important ones that is especially utilized in cases of mob violence because it caters to punishment of criminal conspiracy, that is more than one person acting in tandem with a particular objective in mind against a particular establishment. So this is used in many cases in criminal offences, punishment for criminal conspiracy. Now comes the very important Doctors Anti-Violence Act, which is also meant to contain not only violence, mob violence, but any kind of violence taking place in medical establishments. Yes, we do not have a codified law in the form of a central Doctors Anti-Violence Act, and it is present only in 20 states and union territories and not the entire country presently. And the IMA has been fighting very hard. I'm sure FOGSI people are also aware about this. And only in last year, our Honorable Home Minister Amit Shah said that, we cannot have a separate law only for doctors. In that case, the advocates will also come up, other professionals will also come up. But this idea of a separate central law was introduced. It was made by the Ministry of Health, but it was rejected by the Home Ministry. But nevertheless, we still have enough laws, and these are the states and union territories, including Delhi, which has a law to contain violence against medical establishments and doctors. And not only doctors, but any person working, even trained DAI or an ambulance driver working in a medical establishment can take help of Anti-Violence Act. And this act is not present in these states, Jammu and Kashmir, Jharkhand, Meghalaya, Mizoram, the Northeast 7 sisters, and all union territories. It is not there except Delhi and Puducherry. In the Delhi, just an example, I'm taking Delhi example because see, all of these laws are mostly same. The difference is the state-wise laws that in the present in 20 states and union territories, the difference is only minor. So if I'm taking Delhi, please consider that this law is also almost same, almost to the extent of 90 to 95% in your state as well. So it is called as the Medicare Service Personal Medicare Service Institution Prevention of Violence and Damage to Property Act of 2008. It was one of the earliest ones that was made, and all other laws have been made in 2008 and 2012. Its objective is to prohibit violence against Medicare service personnel, and who are personnel, I'll just talk in a moment, and property of medical establishments. Offender is a person. It could be a leader or member of group who commits, abets or incites violence. That means if there is an incident and the patient's relatives call up some chudvaiya neta or a MLA or a MP, there is some violence like this, so please come and help. So if he says, okay, I'm sending 50 people, you go ahead and start disrupting, creating violence and everything. So as per this act, that if proved, that particular leader will also be an accused person and could be named in the FIR and case tried against him. So this is a very unique thing about this particular law that is there. It is, I've searched, you can search Google. There is hardly any law that gives so much of power to protect medical establishments and medical personnel. Violence is very, Dr. Neeraj Nagpal just now talked about violence defined under the Domestic Violence Act. Violence has been defined under this Anti-Violence Act for doctors also. And it means any harm, injury, or endanger to life or intimidation, dhamki dena, simply haath nahi lagaya, dhamki di, that is also violence. Obstruction or hindrance to any Medicare service personnel or damage to any property whatsoever. And just to, this is not as per the act, but this I have especially prepared for everybody to have a good look. See, all these things that I have just talked about as defined in this act are also standalone laws in themselves as well. Harm is a separate section of law. Injury is a separate law. Endangerment to life is a separate law. Intimidation is a separate law. Obstruction or damage to property is a separate law. Harm is a law under 44 IPC, injury under 44 IPC, endangerment to life under section 320 for grievous hurt and 336 IPC, intimidation under 503, 506 IPC. So my point here is that those 5 or 6 states and some union territories which do not have these laws, Anti-Doctors Act, there are enough laws to protect them already in place. The weakness of our legal system, or probably the entire justice delivery system, is the implementation of these laws. So for obstruction, there is section 283 IPC. For hindrance, there is 228 IPC, and for damage to property, 425, 427 IPC. And these are more laws that are already there in our Indian Penal Code from 319 to 322, 323 to 326 regarding grievous hurt and its punishment, which can be used effectively. See, as I told in the beginning statement, that the problem is not with the laws, the problem is with the implementation. So if we have this knowledge that there are enough laws, we can at least approach the investigating authorities, the courts of law, that yes, please book the accused persons under these laws and arrest them and start push for a charge sheet through the police to be filed against them and take action against them. An institution has been defined under this law. It is a medical establishment of all Ayurveda, Unani, Siddha, allopathy, everything, whether private or government. And personnel, as I said, it is any registered medical practitioner, anybody who is not registered, a nurse, paramedical staff, ambulance driver, even medical students who come for training, trained DIs, especially in the state of Gujarat and Punjab, are also included as medical personnel who can be protected under this law. And the penalty for causing damage or injury to medical personnel can be imprisoned up to 3 years. In Punjab, although it is only 1 year, but in Tamil Nadu, it goes up to 10 years, which is, very strong, I would say. And there is provision of fine also up to 50,000 rupees or both, plus recovery of twice the purchase price of the equipment. So if some infrastructure equipment has been damaged, and if you have a bill for the same, then you can claim through the process of court a price up to twice the purchase price of that equipment, irrespective of whether it was 5-year-old or 10-year-old. In Goa, the offender shall have to deposit 50,000 to 1 lakh rupees in the court when the charge sheet has been filed. The laws in Goa says that one does not have to wait for the final judgment. Accused persons will have to deposit this amount in the beginning of the case itself. And if the patient say that, yes, how are we going to address the problems that we are facing in the medical establishment, the government says that it can conduct inquiry. And anyway, we well know that there are more than 10 authorities the patient can approach for complaints against doctor. It is a non-bailable, cognizable offense. That means the bail cannot be granted from the police station itself. It can be granted only by the court, and the cognizable offense, that means any police officer can take action against it. Although it is bailable in the state of Maharashtra and Odisha, but in all other 18 places, it is non-bailable offense, which is a very good thing, I would say. But then the idea is of this presentation that we should be having this copy of judgment, this law every time with us, whenever we move around outside our residence. Who can make a complaint? The law says the head of institute or authorized representatives, but sometimes the head of a private institute or government institute, they refuse that, no, we are not going to, hum is chakkar mein nahi padna hai. But for that, at least there is this partial solution in Delhi, but we can have this similar solution in all other places in the country, where a order by the government says that the institute head shall have to accompany to file a FIR against the accused persons if there is any evidence of violence or abuse by the patients against any medical personnel. So we can take help of this knowledge to approach authorities in our states. who can investigate, minimum sub-inspector of police, and the case will go to a metropolitan magistrate. And can damage of property be recovered? Yes. As I said, twice the amount as per bill can be recovered. And if the person refuses to pay, it can be recovered as land revenue through the respective court of law. So the central law proposal has been rejected by the Ministry of Home. We always recommend that you should have a public notice like this and a poster like this, which says, in association with Delhi Police, the Delhi Medical Association has issued this poster to all the medical establishments. We always have this at the main gate and outside the labor room, OT and ICU to discourage any act of violence. So if there are any questions, I'll be happy to take. Thank you so much.
Thank you very much, Dr. Agarwal, for your such a very nice talk on mob violence, and it was very elaborate. Thank you very much.
Thank you, ma'am.
If there are any questions on the chat box, then please answer them there.
Thank you.
So I hand over
Thank
to
you, Dr. Gaurav. It was
Thank you,
very
Dr.
comprehensive and informative talk. Thank you so much.
Thank you.
After this informative talk, let's go to the next topic. Penalties under MTP Act, PCPNDT Act and POXO Act by none other than Dr. Richa Sharma. Dr. Kiran, can you just introduce?
Yes. Dr. Richa Sharma, she is dynamic leader and she is chairperson of MTP committee 2024, and she has written many books. She has many awards to her credit, and she is very hardworking.
Okay, thank you, Dr. Kiran. Thank you so much. Okay, is my screen visible?
Yes, ma'am. Yes.
Okay. Okay, a very good evening and a warm welcome once again to all the delegates, faculty and the speakers and the chairpersons. So now in another 10 slides, I will be very, very brief, and another few slides I'll be speaking about what are the offenses and the punishments which are covered under MTP, POXO and PCPNDT Act. Now these few slides are very, very important. It is not to scare anybody, but it is just that we should be aware of each and everything to have the safe legal practice. And I bring greetings from University College of Medical Sciences and GTB Hospital, Delhi. So yesterday we learned what is the MTP Act. Now just in another 2 slides, I will briefly cover so that you can understand the offenses about the MTP Act more clearly. So MTP Act clearly defines who, when, where and documentation. The person who should do the MTP, the place where MTP should be done, then the indications, and then the paperwork. Now, these 4 things are very, very important. Now, this one slide is very important. Now, we learned yesterday that till 20 weeks, 1 registered medical practitioner opinion is needed, and 20 to 24 weeks, 2 registered medical practitioner opinion is needed. Now, who can do the MTP and who can give the opinion for MT is very, very important. Now, the registered medical practitioner, PG, having PG degree or a diploma in Obs and Gynae, they can do the MTP by medical or surgical method up to 24 weeks. Even the MBBS doctors who have the 6 months of complete house surgency in Obs and Gynae or 1 year of experience in Obs and Gynae, they can also do MTP up to 24 weeks, and they can also give the opinion till 24 weeks. Now, up to 12 weeks, the rules are same. Again, MBBS doctor can give the opinion and they can do the MTP by surgical or medical method, provided they have assessed 25 cases of MTP and 5 has been done by them. Now, new thing which has been added after amendment is that MBBS doctors, they can do MTP by medical method till 9 weeks if they have 3 months of experience in Obs and Gynae, or they have performed 10 cases of MTP by medical method only. So these are the people who are entitled for these period of gestation MTP. Now, beyond 24 weeks, medical board will take the decision, and the decision will only be regarding the fetal congenital anomalies. And any other patient, for example, the sexual assault, they come after 24 weeks or unmarried after 24 weeks also, they are not covered by the medical board. They have to file the writ petition. So this is very important. And after 24 weeks, even if they get the permission for MTP, 2 RMPs have to perform the MTP. That means the 2 RMPs name has to go in the paper. So now this indication slide is very, very important. Now the gestation upper limit, it is increased in certain categories. So this is very important. So up to 20 weeks, we all know there were the 5 indications. Contraception failure, it will cover married as well as unmarried. So these are the 5 indications which will come under 20 weeks. Then 20 to 24 weeks, only 7 category of the women. Those are the victims of the assault, rape, incest, minors, or if they have become widowed or they are divorced, physically disabled or mentally challenged women, or fetal congenital malformations. Now we have to be very careful about the malformation because it is those malformations which are incompatible with life, or if they lead the baby will be having the physical or a mental abnormalities or the serious handicap after birth. Only those malformations are covered under this act. And after 24 weeks, it is only and only for the congenital anomalies. So these are the indications which are very important. Now, next is the place where MTP can be done. Government setup, it can be done, and government places, they don't have to take the approval. But the private health facilities, hospitals or clinics or dispensary have to take the approval from the government, that is district level committee. Documentation is very important. These are the 4 types of the forms which I have discussed on the day 1. These are the consent form C or the RMP opinion form. That is form 1, form E or form D, depending upon which period of gestation you are doing MTP. Then monthly reporting form 2 and admission register form 3. Now these forms have to be filled. Either you are doing MTP by medical method or surgical method. Either you are doing in first trimester, second trimester, or any other trimester. So these 4 forms have to be filled. But this should not be filled if you are dealing with the ectopic pregnancy or incomplete abortion or missed abortion. So that is not covered under MTP Act. So now coming to the, what are the offenses which are covered MTP Act? Now they have the common feature that all the offenses, they are considered as cognizable. Arrest will be there without a warrant. They are non-bailable, means these are considered as the serious offense, and bail will be a matter of discretion, not a matter of right. Then they are compoundable. That means the parties cannot compromise. Once the complaint has been lodged, then there will be the investigation, police case, or the punishment. So you have to be very careful with that. So now if the termination of the pregnancy is done by the person who is not entitled or who is not authorized, or if it is done in a place which is not approved for MTP, so there will be rigorous imprisonment 2 to 7 years on doctor who is doing the MTP and as well as the owner of the hospital. Then if there is a failure to maintain the records, documentations, consent, admission register, now initially there was a fine of 1,000 rupees, but now there is also 1 year of imprisonment can be there in addition to fine on the concerned person. Then there are various sections which are associated Indian Penal Code sections. So now they also clearly mention that section 312. Now if the MTP is done without the indications, I have shared the one main slide where there were 5 indications till 20 weeks, and then 7 indications till 24 weeks, and then congenital anomalies after 24 weeks. So if MTP is done without the listed indications and the pregnancy is up to 5 months, then there will be an imprisonment up to 3 years or with fine on the person who is doing the MTP, and as well as the woman who is undergoing MTP is also liable for that punishment. And if the pregnancy is more than 4 to 5 months, then the imprisonment can go up to 7 years or up to 10 years with a fine. Now, another section is 313. Now, if MTP is done without the consent, then it is a very serious offense. There can be a life imprisonment or up to 10 years of imprisonment on the person who has done the MTP. Now, section 314 IPC, now it is according to this, if the death has occurred because of MTP, but you have taken the consent for MTP, then there can be the imprisonment of 10 years with fine. So it doesn't mean that you don't do MTP, but it only means that you should have your paperwork documentation in place. You should use the correct drug protocols which has been given by the government of India. And on the day 1, that is day before yesterday, we had discussed all the drug protocols and everything. So as long as your drug protocols, your paperwork, consent, everything is fine, you will be medico-legally safe. But if there's any flaw, then you might be held. So now if there is a death because of MTP and consent is not taken, it is a very, very serious offense. Life imprisonment or up to 10 years with fine can be there on the doctor who have done the MTP. Now coming to the POXO Act. Now POXO Act also, it was very elaborately, it was discussed on day one. And this act was enacted basically to protect the children from sexual offenses and up to 18 years. And this includes both boys and girls. That means the protection is there for both boys and girls. And this act, it has included a lot of offenses under it. That is physical as well as non-physical contact form of abuses. As you all can see, from the complete or partial penetration to non-penetrative assault, stalking the child, pornography, exhibitionism, everything has been covered in this act. And this is a very stringent act, very serious act to protect the children up to 18 years. Now, as the citizen of our country, it is our duty to report each and every case of child sexual abuse. So we can report to the child helpline number 1098 or to the local police station or special juvenile police unit. Now it is our duty to report such cases, and if we fail to report such cases, there can be the imprisonment of 6 months. Now these are the various offenses and the punishments which are covered under POXO Act. Laws are very severe. It provides equal security to both male and female children. So there's a death penalty for the rape of girl less than 12 years. And if she is less than 16 years, then minimum of 10 years to maximum of 20 years, the punishment is there. Then there are other grades of punishments, like if the child is involved in touching the private parts or instigating the child to touch the private parts, then there will be a punishment from 3 years to 5 years to 7 years or even the life imprisonment. And in case of pornography, the minimum of 3 years of imprisonment can be there, and the maximum of life imprisonment can also be there. And then if we don't report the child sexual abuse, then we are liable to get the punishment of 6 months. Now the violations and the punishment and the offenses under the PC-PNDT Act was also comprehensively covered on day one. Now this is just a brief slides I have put. Now again, the offenses which are under PC-PNDT Act, they are also cognizable, non-bailable and non-compoundable. I have already explained what these terms mean. So now we are supposed to display the copy of the this disclosure that the disclosure of the sex of the fetus is prohibited under law. So if there is non-availability of the copy of this PC-PNDT Act in the registered center, or there's a non-display of the registration certificate in the center, or there's a non-display of this disclosure, then the punishment can be there, which can extend to 3 months or with fine, or it can extend to 1,000 rupees. And then for the first offense, and then for additional offense, 500 rupees per day can be again come as an offense. Then okay, so now if there is any sort of advertisement is there in any hospital or any diagnostic center which says that they are doing the preconceptional and prenatal determination of sex, so that also is a very serious offense under PC-PNDT Act. And then again, imprisonment can extend to 3 years with a fine, which can extend up to 10,000 rupees. Now the centers which are not registered, and those centers also include the centers where there are portable equipment which are capable of detecting the sex before or after conception. So in that case, the centers are not registered, then also it is considered as a serious offense, and any such equipment, if whatever is available there, can be sealed and seized by the appropriate authority which is concerned, and then the punishment can be there, and even the penalty also is there. Now, if there is the irregularities in the registered center, for example, if the owner who is doing the ultrasound or the employee who is doing the ultrasound and they are not qualified to do the ultrasound, then also it is considered a serious offense, and it can lead to the cancellation of the registration of that place. And then the record keeping also is very, very important. Especially we have to keep the form F. We have to fill that updated form F, because if there's irregularity in this form, then also it is considered as a major offense, and that can also be punishable under the PC-PNDT Act. So these are the few offenses and the punishment. So just to have the medical, legal and safe practice, it is always better to know all these new offenses and punishments. And it is always better to do something correctly than not at all. It is better to be safe than sorry. Thank you so much. Now we are running short of time.
Thank you, ma'am. Thank
We are
you
running
for-
short of time. So now quickly we move on to the very interesting panel, that is the litigations in MTP. And I invite the moderator, Dr. Kiran Koti, sir. So now I request the chairpersons to please introduce Dr. Kiran, and then we can have the panel.
Dr. Kiran Kirkoti he is Vice President ICOG Pune, and he's Chairperson MTP Committee. He has many publications to his credit. He has written ICOG Suraksha booklets, and he is editor of many books, and he has given many talks at national and international level. Welcome, sir, for your being moderator in the panel. And our panelists are Dr. Mandakini Meg ma'am, Dr. Anuradha Panda ma'am, Dr. Nishi Gupta, Dr. Deepa Gupta, Dr. Rajkumari Praneshwari, Dr. Sunita Agarwal, Dr. Amita Umesh, and Dr. Ashok Naniwal. Welcome, sir.
Now please unmute Dr. Kiran. I think he's not able to unmute.
Actually, Dr. Mitali is not answering my messages. I've been sending her messages to allow all the panelists in. She's not answering my messages. I don't know if you have Dr. Mitali's. I have Mitali's number. I don't have her number.
Some of the panelists, they are not able to.
Ma'am, everyone can unmute.
Yeah. Now,
Now you are audible, sir.
please allow me to share my screen. The host has disabled screen sharing. Please allow me to
Sir,
share.
please share. I have given the permission. Yes.
Thank you so very much. So at this outset, a very big thank you to Dr. Risha Sharma, Dr. Lakshmi, Dr. Ashok Kumar, and the entire team of FOGSI for allowing us to present this particular topic on a very interesting. And I would really like to congratulate Dr. Richa for bringing out this course. So without much ado, we will go to the medico-legal cases in MTP. And I would like to invite the panelists, Dr. Mandakini Meg, Dr. Anuradha Panda, Dr. Nishi Gupta, Dr. Deepa Gupta, Dr. Rajkumari Praneshwari, Dr. Sunita, Dr. Amita Umesh, and Dr. Ashok Naniwal. Are they all? Everyone is there?
Yes.
Yes, most of us are there. Yes.
Okay, fine. So are the slides visible? Is it okay?
Yes, sir. Yes, sir.
Great. So we will begin with the first case. Okay, we'll rush through about 3 to 4 cases. So this was the first case, which was the Andhra Pradesh Court, President Justice Parvat Rao and member K. Rangarao. So this is the case of Lalita Krishna versus Deepa Nayas. Let's see what the case was. So the MTP was done at 5 to 6 weeks of pregnancy by the opposite party number 1. The patient got her ultrasonography done at some other place after 7 days, and the fetus was found to be intact. Now, after 2 to 3 weeks, MTP was done at another place by a different doctor. So the lawyers sent a notice to the first doctor for a compensation of rupees 2 lakh. The case went to the district forum, and district forum found that the doctor was guilty of negligence and awarded the compensation. So my first question is, Dr. Mandakini Meg, madam, is she there? Okay, if she's not there, anybody else can take the first question. Madam is, I think, on her way to Cochin. So anybody, what is your opinion on the continuation of the pregnancy post MTP, and is the doctor guilty?
The doctor is not guilty.
Yeah.
Because anytime we can have that there is chances in a very early pregnancy that we may not be able to remove the product of conception, and at 5 to 6 weeks, that's why we usually ask for a medical termination, so that we have more chances that it will come out. And sometimes in surgical, it may be a very small pregnancy somewhere, and we may not be able to get it out every time unless we do ultrasound guided evacuation.
Okay. Again, my screen is not visible. What has happened? Please allow me to share my screen. Yeah, fine. Is my screen now visible? Okay.
Yes, sir. Yes, sir.
Great, great. So now let us see what happens. Okay. Now the doctor obviously denied that the pregnancy had continued, says that she has a vast experience of doing MTP and her hands and she can never fail. She alleged that the patient is lying by saying that the MTP was completed at some other place later on. That is, the patient got pregnant again and she had conducted the MTP later. However, the patient was smart and submitted the proof of the MTP done, the USG report of growing and the intact fetus with the dates. So the compensation which was calculated in district forum was cost of mental and physical agony 500 rupees per day, amounting to about 8,000. Cost of the first MTP, that is 1,200. Cost of the second MTP 850. Cost of ultrasonography and cost of the appeal. So Dr. Anuradha, in this case, if you are the doctor, would you further appeal to the higher court?
Yes, I would. Because there are all chances that it could be a failed MTP. I would, but I wouldn't be very confident in saying that it would never fail in my hands. Well, years of experience, I would say, but I could say even with years of experience, the chances that it may be a failed MTP.
Right. So let us see what happened. The state forum upheld the order of the district forum, but they reduced the compensation and did not approve the 500 per day. They did not offer the cost of the second MTP as a part of compensation because then the argument was that the patient should have gone to the first doctor itself for the MTP and then the cost of the second MTP would not have been there. So this was the result. Now the take-home message from this particular case is let us not be overconfident, as Dr. Anuradha rightly said. Also, never be so sure that a patient is lying. You know, somewhere there is a communication gap. If you tell the patient that you are lying, and if the patient is not lying, if the patient is right, then obviously she can go and go to the court. And, this obviously was a case of a communication gap. All of us know that a MTP can fail or early pregnancy can definitely continue. So in these cases, careful handling of the patient is more important. And also, what the doctor could not show that in the consent itself, they should document, it is written that the MTP can fail. If at all you download the FOGSI uniform consents, apart from the consent in the form C, which Dr. Richard rightly said, if you download the FOGSI consent forms, they are elaborate and they definitely mention that a surgical MTP can fail. So if all these documents were given, it would have been tackled up in a bit empathetic way, then of course these litigations would not have taken place. So this is the take-home message from this case. Now let us take the second case. The patient was admitted for vomiting by general practitioner. The UPT came out to be positive. She was referred to a gynecologist. Of course, he did to rule out pregnancy, USG to rule out ectopic pregnancy. And the patient insisted on performing an MTP. Now, the risk was explained as she was the case of previous C-section. The doctor went ahead and did an MTP, but obviously no products could be obtained. This happens with us many times. And the patient was told that early pregnancy or ectopic can be missed. And a repeat DNC was advised. Now the patient did not get to KMA discharge. After 7 days, she went to another doctor who found that the pregnancy was continued, and that doctor did an MTP by suction evacuation. Now the patient went to the court and alleged that if suction evacuation was done in the first place, the products would not have been missed. Instead, the doctor did a DNC, which is not proper MTP. So this was the argument. That is, this is argument of suction evacuation versus DNC. So Dr. Nishi, what would you do for early pregnancy? And was this doctor guilty? Dr. Nishi?
Please unmute yourself.
So this doctor is not at all guilty, because in early pregnancy, there are very well chances of it being missed by doing a DNC or suction evacuation. And nowadays, we should resort to the medical methods of termination. So this doctor could not be guilty because he explained each and everything and told that patient to come back after a week or 10 days.
Okay, fine. Fair argument. Now here, what we need to do is, what we need to understand is, we need to explain the patient about suction evacuation, DNE, and of course, the medical termination. So what the state forum did, they referred to the expert and textbooks that there are chances of missing the products at early stage of pregnancy. And most importantly, DNC was also a method of MTP. So the order of district forum was set aside and the appeal was allowed. So take home messages again, communicate as Madam rightly said to the patient at an MTP and early stage can definitely fail. DNC and suction evacuation can be defended as methods of first trimester MTP and start resorting to medical abortions. Now in medical abortions, what I would like to tell the audience and everyone is that although it is written that sonography is not a part of medical abortion, it is not mandatory, but definitely one must do a sonography to rule out ectopic pregnancy, number one. And number two, in medical abortion, unless until you see the gestation sac, there is no point in giving mifepristone. We have done a lot of cases wherein the pregnancy test is positive, ectopic pregnancy has been ruled out, but very small, tiny gestation sac, at times the drug may fail. So please remember that whenever we are doing a medical abortion also. So what we normally do is at least let the gestation sac be around 5 weeks, not a very early 4.5 week gestation sac. We do not go ahead and terminate. Let it allowed to be 5 weeks. Probably it may have to do with the receptors that may be activated, the number of progesterone receptors that may be activated. Okay, fine. Now let's go to the third case. That is the case in Gujarat. This case was a third gravida, 13 weeks pregnancy. USG was done as usual. The written consent for MTP was taken. The doctor took the statement of the patient and husband in front of the police that the written consent was given for MTP. He started doing a DNA. There was atonia. There was hemorrhage. The husband was called into the operation theater, asked to get A negative blood. Okay. So here, Dr. Deepa, according to you, is everything going correct in this particular case? If Dr. Deepa is, yeah, Dr. Deepa, please unmute, madam. No, madam, please unmute. Yeah.
Yes, yes, sir.
Yes, madam.
Yes, sir. Sir, in this thing, in this case, I think there needs to be a very good history of the patient is very important. We need to take a history of whether the, any obstetric history of hers, whether it was a previous cesarean or a normal delivery, because the pregnancy is about 13 weeks. Secondly, we need to take a detailed medical history also, because whether she's a hypertensive, because we just want to rule out if any high risk factor is there in this particular case of MTP. And secondly, some basic investigations like complete hemogram or blood group should be done. And in this particular case, it was a rare blood group of A negative. So there's no harm doing a cross matching before the procedure. And the most important part is a written consent has to be taken in the form C. And secondly, I am always regularly doing a information consent, written information consent with the patient, that is like in the language whatever the patient understands, including all the complications and all the details of the procedure to the patient, and in whatever language she understands. And the consent, and in this particular case, the missing part was the consent form, or the consent was not preserved for 5 years. So in all the cases, in all the MTP cases, Form C has to be preserved for 5 years.
Yes, very, very rightly said. Yes, as far as the documentation is concerned, yes, you rightly said, Form C is the most important form and we need to preserve it for 5 years, the last entry, number one. Number two, take home message could be that for all cases, especially of second trimester abortions, now this was a case of 13 weeks with previous C-sections, but technically it's a second trimester abortion. So for all such cases of second trimester MTPs, one must keep blood grouping and cross-matching ready with at least one bottle of blood, because you don't know what can go wrong, especially with the previous C-section. You can perforate, there can be adherent placenta, especially in the case of previous C-section. In early first trimester, that is 8 to 9 weeks, there could be products, the placenta could be adherent, especially to the lower segments. There are multiple things. So especially in the case of previous C-section, it is desirable. I'm not saying it is mandatory. It is desirable that we keep everything ready, done to cross-match, and then proceed to the case. Now let us see what happened. Emergency hysterectomy was done with the help of 2 more experts doctors. So this doctor definitely called for 2 more people. It was subtotal hysterectomy, obviously, because since it's an emergency, they did not do a total hysterectomy. The uterus was not sent for HPE, 4 bloods, etc. 12,000, but again they settled on 6,000. Again, so what is the opinion of the forum? Dr. Rajkumari.
So regarding this case, it is a government hospital. We don't charge, but it is a private. Naturally, we have to charge.
Yes.
And then about this, after the cases only that the compensation and all the rescheduling can be done, but the charging wise, I think we should charge it in the private setup.
Okay. And second question was, can the hysterectomy be done without the patient's consent?
Actually, this is a 13 weeks pregnancy. This is a second trimester abortion. So this is an admitted case. After admitted case, over and above the FOGSI, we used to write present information consent and informed consent. We used to tag. There we have written regarding the complications that she may enter with hysterectomy. But still, when we wanted to do again, even if we ourselves, we cannot explain. Some we can send out some junior, and then we have to take the verbal consent and the signature from the husband preferably. That is better.
Okay, fine. So bottom line is definitely, since it was an emergency case, they definitely told the husband. So that was, of course, patient consent could not be taken because she was under anesthesia, but some relative consent was taken for this. Now the doctor allegedly refused to give the discharge card, receipt of payment reports and paper. They allegedly asked them to sign the blank consent form and allegedly threatened that husband. So Dr. Sunita, any defense against these allegations? Dr. Sunita, madam, please unmute yourself, ma'am. Yes, madam.
Yeah, the doctor can deny, he can refute all allegation because the patient was there for 17 days. So how he can treat this patient because he was taking care of this patient for 17 days. If the patient was under the pressure, he was afraid of doctor, so he can shift his patient to another hospital, but he was taking doctor facilities, doctor service for 17 days. And after taking treatment for 17 days, and the bill was about 6,000, it pay only 3,000. So first point was clear, he was not under the pressure, he was not under the threat. And second, because the informed consent was taken for MTP, everything was detailed, patient know everything. He know this was subtotal hysterectomy, cervix was left, he know everything. Technically, he knows everything. So how he was in darkness. So this allegation was false, and because in the written consent was not given by the patient husband to take all the reports, because it was MTP is totally confidentially. If the patient husband give written consent to take all papers, but he do not give written consent to take all reports, so all allegation was the false.
Okay, fairly said. What we can see is, number one, in case you feel that the patient can allege, what we have done everywhere is, please install CCTV cameras. Please install CCTV cameras, especially in your OPDs and all the public areas. Installation of CCTV cameras is hardly a matter of rupees 1 to 1.5 lakh rupees. But again, one must remember, because every day anybody can allege anything. However, if the CCTV camera is installed even in your consulting room, not in the private area, but in the consulting room, then you can tell the patient that, okay, send me the location where this allegation was done or where I have threatened you. So this is number one. Number two, the importance of CCTV camera is that many a times relatives, they especially barge into the consulting room and they start abusing the doctor. So in this situation also, if there is a CCTV camera, even if the DVR is damaged, the CCTV camera recording can be there on the mobiles. So that is very important. So take home messages, please install such cameras along with audio also, not only the video. Okay, there has to be an installation with the audio. So there is a different audio device which is given to which is attached to the DVR recorder, which records even the voices. So not only audio, the video is also recorded. So this is one. Number two, even if you are demanded any kind of papers, indoor papers, the law states that you still have about 72 hours before you can hand over the papers. Now this happens especially if the police barge in and ask for papers, or if any, forget about MTP, for any other case. So the police can come and ask for the papers, the relatives can come and ask for the papers. So always number one is ask them to give in writing that you need the indoor case papers, number one. That writing should include the purpose of having the indoor papers. And once that in writing, they give you the request letter. After that, you have 72 hours to comply before you hand over the papers to the police or anybody else. Now, the next question is, in case the police is not listening, in case they force you to give the paper, for example, you are writing the paper in front of you and they snatch away the paper, or in that particular situation, you have to write on the paper that paper has been given to me, and I am submitting the paper under stress or under force or threat or coercion, and the paper is yet to be completed. So write it on the paper and only then give it to them. No problem, because then that cannot be evidence, because you need to complete such papers before the medical legal case can stand. So again, please remember that 72 hours is the take-home message before you can hand over the papers. Okay. Now, again, yeah. So written consent, blood grouping for cross-matching, and expert witness. So now coming to the next case. Facts of the case was MTP was done, bleeding was there off and on. The patient was diagnosed as dysfunctional uterine bleeding during follow-up and treated with medicines. The patient saw another doctor, there was no relief. The ultrasonography showed incomplete abortion, suction evacuation was done, and the complaint was allowed by the state forum. Very commonly, it can happen that an incomplete abortion can occur in very good hands. So, Dr. Amita, madam, anything wrong in this case? Dr. Amita ji?
Yes, sir. I feel that even post MTP, the patient comes with the bleeding or the spotting PV. The most common diagnosis of incomplete abortion should have been kept in the mind. And in the first instance itself, one has to do the sonography and rule out the possibility of the incomplete abortion rather than to treat her for the DUB and let the patient wander over here and there. So I think the first step should have been done about the sonography and the diagnosis, which has been missed.
Yeah, you rightly said, madam. Especially all cases of post MTP PV bleeding, one is in incomplete abortion and other is a AV malformation. These are the two things that one must rule out, and your sonologist has to know the difference between AVM and the retained products of conception. They should throw the Doppler and see the vascularity and then report it as a AVM or a incomplete abortion, because in case you start doing curettage in AV malformation, that can result in another torrential bleeding. So one must keep those things in mind. As you rightly said, that ultrasonography should have been done in this particular case, and simple 4 tablets of misoprostol could have solved this thing. Now, what was the judgment? Okay. The judgment was no affidavit was filed by the complainant to support the allegation. Fortunately, the doctor got scot-free and the appeal was accepted and the order of the commission was set aside. Now, I think this should be the last case. Okay. A multigravida with early pregnancy wanted MTP for failed contraception. A DNA was done with curettage and sterilization was also done. The doctor has got a vast experience of 15 years in a recognized MTP center. The patient came after 15 days with pain, loose motions and vomiting. And on examination, a failed MTP was diagnosed and USG showed 10 weeks of pregnancy. So this is clear-cut case of a failed medical termination of a pregnancy. Dr. Ashok ji, if at all you are there, can this happen, Dr. Ashok sir?
I think Dr. Ashok has not joined.
Okay, anybody else can take that question. Anuradha ji, would you like to take this question?
Yeah, in a failed abortion can happen. It is usually incomplete abortion, and that's presented with vomiting and all that. We should even think of other complications other than incomplete abortion, because if we had caused any perforation or anything else, bowel injury, that could be a more relevant thing than incomplete abortion, and we should be asking for a ultrasound in the first go.
Perfect. So bottom line is this can happen. So the doctor rightly said he advised termination of pregnancy and also went ahead and offered to do it free of cost. Now the patient continued the pregnancy in spite of this. Okay, the patient continued the pregnancy, delivered a boy, and later alleged negligence and demanded a compensation of around 5 lakh rupees. So now what will you do?
I'll appeal in the court. Actually, I think I have not done anything wrong.
Okay,
So
great.
I should ask for appeal in a higher court to
Great. So
absorb.
yes, as you rightly said, the doctor was right in whatever she was doing. The MTP Act was visited. The gynecologist is RMP under provisions of the Act. The MTP was done under valid indication, and they gave importance to Section 8 of the Act, which mentions about protection for action taken in a good faith. It says that no suit or legal proceedings shall be done against MTP against any RMP for any damage caused or likely to be caused by anything which is in good faith done for intended to be under this Act. So whatever the doctor had done was in good faith, and so this case was dismissed. Again, the reference was made to a study conducted by the MTP committee of FOGSI, and 100% termination of pregnancy is a myth. So these were the cases. The percentage of cases for failed MTP in first trimester was 0.94, and in second trimester was around 2%. So these references were made and then were presented at the time of case. So the take-home message by this is Section 8 of the MTP Act provides immunity to us as far as the legal cases are provided we have acted in the purview of the Act and the act of omission was in a good faith. Okay, so this is very important. I think this should be the last case. Do we have time? Anyway, second, a patient with previous C-section, clinically 6 to 8 weeks pregnancy, the laminaria tent was introduced. There was profuse bleeding during MTP because of cervical pregnancy. Hysterectomy was done as a life-saving measure. The allegations by the patient was that she saw the doctor only for diagnosing pregnancy and not for termination. The doctor did MTP unnecessarily because pregnancy was normal. She did not do a pre-op USG. There were lack of facilities in the hospital and the POCs were not sent for HPE. Now, here the National Commission judgment was that a patient went to the doctor for diagnosing pregnancy and not for MTP was proved to be false because she had a positive UPT done elsewhere beforehand. So patient already knew that she was pregnant and then she had gone to the doctor. The pre-op checkup was done, again that was approved. The doctor came to the witness box for examination many times, but the patient or husband did not come. Again, take-home messages always go to the witness box whenever you are called by anybody, because it is seen as a lack of respect to the judge or to the judgment seat in case you are not present at the time of your hearing. Okay. Now here again, hysterectomy was a life-saving procedure and not a negligence. This was again proved by the doctor. Not much importance was given to the notes of the anesthetist. Forget about it. So again, the Supreme Court considered that did the patient have a normal pregnancy? Did the doctor fail on her duty by not doing the pre-op USG? Did she do the MTP negligently? Was it necessary to send the products of conception for SP? So these were the various references, role of USG in MTP. Dr. Raja was called as expert witness. Then again, principle and practices of USG in OB/GYN said that cervical and ovarian ectopic are rare and difficult to diagnose. Again, these were all the textbook references which were given. Again, these were the textbook references which were given, and in the present case, it was ruled that USG is not a standard practice. Although it is said that it is desirable, it is not mandatory. Hysterectomy was a life-threatening procedure. Again, putting the laminar trends, etc., was also taken into consideration whether HP of uterus was needed. Again, so no negligence was proved and the case was dismissed. So the take-home message is that we must learn from these cases how to defend. Whenever we have any, rather as a matter of fact, we must have a list of all the defense cases with us. For example, failed MTP, what is the defense? Hysterectomy during cesarean section, what is the defense? Table death during the cesarean section, what is the defense? What are the case? Which pages? We have standard Williams textbook, Datta, whatever textbooks that we are referring. we should have a standard defenses. Key page number so and so written in Williams, which is the international textbook. It says that amniotic fluid embolism is likely even in case of previous C-section or even in the case of C-section or a normal delivery. So that should be our first line of defense. Or PPH can occur in all cases, even if there are no antenatal risk factors. Again, which page, which book? Okay. Here so we have the PIGO bundle approach guideline also. So we must have a set of defense guidelines with us, so that in case there is any such case which we complicate or there is complication arising, then we should pick up that line and present it to the court. Okay. So anyway, thank you so much. When the chips are down, if you face some medical legal issues, times are tough, visit us in Pune. We are always welcoming you. Every now and then we have a conference in Pune. So all of you are most welcome to Pune anytime when you see a conference. And do bless us with your blessings. Thank you so very much. And panelists, thank you so much, especially for taking out time on a Sunday night, Saturday night, and gracing this particular panel. And I really congratulate Richa ji, because I see around 375 participants. And really a huge number considering the topic MTP, which is such a common topic. We have been learning MTP since donkey's years now, but still then so many people are logged in, which it's of such a great importance. So if we are open to any questions, Dr. Afreen Amjad has raised his hand, her hand. Any questions in the chat?
Yeah, Dr. Afreen, if you have any question, please put in the chat box. Thank you, Kiran sir, for such a wonderful panel. I mean, you had gathered so many collection of cases and all the court cases. It was really good, and all panelists were my committee members, and they are very active members, and they participated in a wonderful discussion. Thank you so much. And sir, please answer the questions. There are a few questions in the chat box.
Yeah.
Okay, thank you. So now can we proceed to the other topic, Dr. Anuradha?
The next topic is Safe Kit, examination of rape victim by Dr.
Roma Yadav.
Roma Yadav. Can you introduce, madam?
Yes, ma'am. Dr. Roma Yadav, she is consultant, Bhagalpur, Bihar. She is vice president, Bhagalpur, and she is active member of MTP committee. Welcome, ma'am, for your talk.
A very warm good evening to all of you. Without wasting time, I'm starting my presentation. Today, my topic of my presentation is Safe Kit, examination of rape victims. So before going to the Safe Kit, I would like to narrate few lines that rape is a type of sexual assault involving sexual intercourse or other forms of sexual penetration carried out against a person without their consent. The act may be carried out by physical force, coercion, abuse of authority, or against a person who is incapable of giving valid consent, such as one who is unconscious, incapacitated, has an intellectual disability, or is below the legal age of consent. Before starting, I would like to discuss a standard operating procedure for examination of rape victims. Any registered medical practitioner can conduct the examination, and it is not mandatory for a gynecologist to examine such a case. In case of a girl or woman, every possible effort should be made to find a female doctor, but absence of ability of a lady doctor should not deny or delay the treatment and examination. In case a female doctor is not available for the examination of a female survivor, a male doctor should conduct the examination in the presence of a female attendant. In case of minor person with disability, his or her parent, guardians, or any other person with whom the survivor is comfortable may be present. In case of a transgender intersex person, the survivor should be given a choice as to whether she or he wants to be examined by a female doctor or a male doctor. Police personnel must not be allowed in the examination room during the consultation with the survivor. If the survivor requests, her relative may be present while the examination is done. These are few questions which every time people used to ask. The history taking and examination should be carried out in a complete privacy in a special room set up in the hospital for examination of sexual violence survivor. The room should have adequate space, sufficient lighting, a comfortable examination table, all the equipments required for a thorough examination, and the sexual assault forensic evidence kit, that is the SAFE kit, containing the items for collecting and preserving the physical evidences following a sexual violence. Coming to the main topic, the SAFE kit, the contents of the SAFE kit are forms for documentation. These are included inside the kit box. Forms for documentation, large sheet of paper to undress over, paper bags for clothing collection, catchment paper, sterile cotton swabs, and swab guards for biological evidence collection. There are combs, nail cutter, sticks for fingerprinting, scrapings, small scissors, urine sample container, tubes, vials, vacutainers for blood samples like EDTA, plain and sodium fluoride with plain or sodium fluoride, syringes and needle for drawing blood, distilled water, disposable gloves, glass slides, envelopes or boxes for individual evidence samples, labels, stick for sealing, clean clothing, shower and hygiene items for supervisors' use after the examination. These are inside the SAFE kit box. Few items are necessary for the forensic or medical examination and treatment that may be included. These may be wood lamp, wood torch, vaginal speculums, drying rack for wet swabs or clothing, patient gown, cover sheet, blanket, pillow, and post-IT notes to collect trace evidence, camera of 35mm digital with color printer, microscope, colposcope and magnifying glass may be there, toluidine blue dye, 1% acetic acid diluted spray, urine pregnancy test kit, Surgilube, medications. The collected samples for evidence may be preserved in the hospital till such time that police are able to complete their paperwork for dispatch to forensic lab tests, including DNA testing. Now coming to the main topic, the examination of rape victim. Medical examination and reporting for sexual violence, the few points are there. That is the first aid, initial resuscitation, informed consent for examination, evidence collection, police procedure, detailed history taking, medical examination, age estimation if requested by the investigating agency, evidence collection, protocol, it should be protocol-based, documentation, packing, sealing, and handing over the evidence to the police. These are the investigative procedures. Treatment of injuries, testing, prophylaxis for STI, HIV, hepatitis B, and pregnancy, and psychological, naturally, the psychological support and referral for the further help. Moving on, the various steps that can be detailed as follows. Regarding documentation, name of the hospital where survivor is being examined. It should be clear-cut written. Name, address, age, and sex of the survivor. Name of accompanying person and relation with the survivor. There may be 3 circumstances under which a survivor may approach a health facility. Sometimes the survivor has approached on his or her own only for the treatment for effects of assault. In this case, the informed consent must be taken, medical examination and treatment must be done, inform the police, make medico-legal case, and request for permission for FIR. I'm coming to the next. Survivor has approached with a police requisition after complaint. Informed consent, again informed consent, medical examination and treatment, make MLC with number and police station to be recorded. If the survivor is coming with a court directive, again the informed consent should be taken for medical examination and treatment, make MLC with number and police station to be recorded. Sometimes the survivor don't want to file the FIR. In this very case, if the survivor has the right to refuse filing of FIR, but in which case MLC is to be recorded still with documentation of the informed refusal. Documentation for the informed refusal must be taken. Informed consent is to be taken for following purposes. That is for examination, sample collection for forensic and clinical examination, treatment, and police intimation. Few are the other scenario that only in situations when it is life-threatening, the doctor may initiate treatment without consent as per section 92 of IPC. The consent form must be signed by the person, him or herself, if he or she is above the age of 12 years. Consent must be taken from the guardian parent if the survivor is under the age of 12 years. The consent form must be signed by the survivor, a witness, and the examining doctor. Any major disinterested person may be considered as a witness. Marks of identification must be taken, and this should be taken according and the size, site, surface, shape, color, and fixicity to the underlying structure of the marks of identification must be noted. Left thumb impression is to be taken in the space provided. There must be the relevant medical and surgical history should be taken, and regarding the menstrual history, LMP, cycle length and duration. If the patient is menstruating, record and document, and patient may be examined on a further date. Conduct another examination on a further date. There should be a history of tetanus and hepatitis B vaccination. Regarding general physical examination, the pulse, blood pressure, respiration, temperature, and state of pupil, orientation to the time, space, person, and question asked by the doctors. Signs of intoxication, that is by ingestion or injection of drug or alcohol, these all should be examined. State of clothing, is it the same as that worn at the time of the assault? Is it freshly torn? It has stains of blood, semen, mud, etc. Again, the site, size, and color of the stains must be written. Sexual violence history. In case of narrator, survivor or accompanying person, relative details of the narrator to be recorded. Presence of a relative. This is relative is allowed if the survivor is comfortable with the relative. Nature of history documentation in the survivor's own words should be taken. Date and time, location of the incident, number of assailants with the name and relation of the known. In case of physical violence, type of violence, location on the body, history of injury, marks left on the assailant's body by survivor, any weapons used, sticks, acid, burn, gunshots, knife attack, use of drug or alcohol, verbal threats in the survivor's word, attempted or completed penetration by penis, finger, objects in the vagina, anus, mouth. Masturbation of the assailant by the survivor, masturbation of the survivor by the assailant, masturbation history of injury marks left on the assailant's body by survivor. These all should be taken. Oral sex by the assailant on the survivor or sucking, licking, kissing of body parts. Information and location of emission of semen, use of condom, sucking or spitting. Record the history of last consensual sexual intercourse in the week preceding the examination. Regarding the history of in relation to the STD, discharge per urethra, per anus, warts, ulcer, burning micturition, lower abdominal pain, texture, color, odor of vaginal discharge, all should be written clearly. Examination of the injuries, which will be marked on body charts. That is 10 different types of blood, semen, lubricant, actual site, size, color, number of swabs. Body surface, especially on the scalp, face, neck, shoulders, breast, wrists, forearms, medical aspect of upper arms, thighs, and buttocks. These are examined for the signs of bruises, physical torture injury, nail abrasions, teeth white marks, cuts, laceration, fracture, tenderness, any other injury, boils, lesion, and discharge should also be taken. Description of the injury, like the abrasion, which is whether the injuries are abrasion, laceration, incised wound, or contusion. Again, the site, size, shape, color, swelling, signs of healing, simple previous dimension, signs of healing, again taken. Possible weapon of infliction, the weapon may be hard, blunt, rough, or sharp. Local examination of the genital parts or other orifices, external genital area or perineum should be observed for injuries, seminal stains, pubic hair. It is examined for seminal stains and foreign particles, and note is made if shaven pubic hair is there. Vulva, in case of female survivor, inspected systematically for any sign of recent injury, such as bleeding, tears, bruises, abrasions, swelling, or discharge, and infection involving urethral meatus and vestibule, labia majora and minora for introitus, and hymen. Anus and anal orifice should also be examined for bleeding, swelling, tears, discharge, stains, warts around the anus and anal orifice, which must be documented. Relevant swabs from these sites should be collected. In case of oral cavity examination, it should also be examined for any evidence of bleeding, discharge, tear, edema, and tenderness. Vulva in case of female survivor, per vaginum examination or two-finger test must not be conducted for establishing rape or sexual violence. Size of the vaginal introitus has no bearing on a case of sexual violence. Per speculum examination is not a must in the case of children, young girls, when there is no history of penetration or no visible injuries. In case if the injuries are not visible but suspected, look for micro injuries using good light and a magnifying glass, colposcope, whatever is available there. If 1% toluidine blue is available, it is sprayed and excess is wiped out. Micro injuries will stand out in blue. Care should be taken that all these tests are done only after swab for trace evidences are collected. Now coming to the collection of sample. For hospital, laboratory, and clinical laboratory, if requested by the police for age estimation, radiograph should be taken. For radiograph can be advised for wrist, elbow, shoulders, and deltoid examination. These are for age estimation. For any suspected fracture injury, relevant examination, UPT report, collection of blood for baseline HIV status, VDRL, and hepatitis B. For Central State Forensic Science Laboratory, survivor to stand on a large sheet of paper so as to collect any specimens of foreign material, for example, like grass, mud, pubic, or scalp hair. Sheet of paper to be folded carefully and preserved in a bag to be sent to the Forensic Science Laboratory for trace evidence detection. Clothes worn during assault along with the stains, tears, trace evidence to be documented. Swabs for spermatozoa to be obtained within 72 hours. All clothes and samples to be air dried before being packed. Regarding the body evidence, swabs for blood stains, foreign material on the body and the seminal stains. Detection of scalp hair or pubic hair of the accused on the survivor should be collected separately. If there were signs of struggle, epithelial cells under the nails to be carefully collected. Blood is collected for grouping and used in matching and comparison. Collection of blood and urine for detection of alcohol and drugs. Venous blood, 3 sterile vials, plain vial for blood grouping and drug estimation. For drug estimation, sodium fluoride, alcohol, EDTA for DNA analysis. Oral swab for detection of semen and spermatozoa. Regarding the genital and anal evidences, in case of suspected seminal deposits, check for such on pubic hair of survivor and clip the matted portion of the pubic hair. Comb the pubic hair of survivor for collecting same of the accused. Swabs to be taken from the vulva, vagina, anal opening for anogenital evidence. Swabs to be collected for lubricant examination. Vaginal washing is collected using a syringe and a small rubber catheter. 2 to 3 ml of saline is instilled into the vagina and fluid is aspirated. Fluid-filled syringe is sent to Forensic Science Laboratory after putting a knot over the rubber catheter. After doing all this, a provisional clinical opinion should be drafted. It should be drafted immediately after examination of the survivor, basis history and findings of the detailed examination. It is a must-mention aspect of the history of sexual violence, clinical findings, and samples sent to forensic laboratory. An interference shall be drawn basis the findings. An inference shall be drawn basis on the findings. It should always be kept in mind that normal examination findings neither refute nor confirm the forceful sexual intercourse. Hence, circumstantial or other evidence may please be taken into consideration. While formulating the opinion, the following are to be kept in mind regarding absence of injuries or negative laboratory of results. Inability of survivor to offer resistance to the assailant because of intoxication or threats. Delay in reporting for examination. Activities such as urinating, washing, bathing, changing clothes, or douching, which may lead to loss of evidence. And use of condom, vasectomy, or discharge of vas. Now, after that, we will offer the treatment to the survivors. For non-pregnant survivor, azithromycin 1 gram stat or doxycycline 100 milligram BID for 7 days, along with metronidazole 400 milligram for 7 days with antacid. In case of pregnant survivor, amoxicillin, azithromycin with metronidazole is preferred, but metronidazole is contraindicated in first trimester and it should be kept in mind. Hepatitis B, for hepatitis B, draw a sample for hepatitis B surface antigen and administer. Treatment guidelines, pregnancy prophylaxis. 2 tablets of levonorgestrel within 72 hours, and it can be repeated if vomiting occurs within 3 hours. Or
Madam, we are actually getting a little late. Can you just
Yeah,
wind
ma'am,
up?
just I'm winding up. Ma'am, I'm just winding up.
Yes,
These
madam.
are the treatment guidelines. Everybody knows this is the last slide, ma'am. Clean with treatment, clean with antiseptic or soap and water. If the survivor is already immunized with TT, no injury, TT is not required. And treatment guideline for post-exposure prophylaxis for HIV should be given if the survivor reports within 72 hours of the assault. One very important is the please follow up. Please emphasize the importance of follow-up to the survivor. It is ideal to call the survivor for re-examination 2 days after the assault to note the development of bruises and other injuries. Thereafter, at 3 and 6 weeks, all follow-up should be documented. Repeat test for gonorrhea, test for pregnancy, repeat after 6 weeks for VDRL, and assess for psychological sequelae and treatment for for her psychological support. So coming to then, rape is not just a physical violent act perpetrated against one victim. It is an assault on humanity. Thank you very much. Thank you for giving me the opportunity.
Thank you, Dr. Roma, madam, for a very elaborate lecture. Thank you very much. We had lots to learn. Now going to the next speaker, it is Dr. Satya Sudhakar, who will be speaking on Biomedical Waste Management Act. Dr. Satya, and she is a consultant obstetric gynecologist at Kaveri Hospital, Salem, and she is a very active member of the MTP committee. Over to you, Dr. Satya. Madam, would you please stop sharing the screen?
Yeah. Good evening, everybody. I thank Dr. such an opportunity. I thank Dr. Lakshmi ma'am for giving me such a good opportunity to present on biomedical waste management. I think I'm all in my slide here.
Yeah, your slide is not seen. Dr. Roma, please, you have to stop sharing the screen, please. Can the audiovisual people please do it? Jignesh or...
Ma'am, she had already stopped the... Ma'am, you can share the slide.
Dr.
Satya, ma'am.
Roma's screen is visible. So she has to stop sharing, I think. I'll just call her.
No, ma'am, she have already stopped it.
No, Dr. Anuradha, she has stopped sharing. Satya,
Yes,
you can
ma'am.
share your screen.
Ma'am, I'm not able to share.
Okay, then we
Dr.
go to
Satya,
the
you can
other
be at the
speaker. You
bottom.
do one thing, Dr. Satya, we are getting very late. Okay, you send your PPT to Dr. Anuradha. Meanwhile, we'll take up another speaker.
Ma'am, I've got it actually.
Just try once more, no, please.
Yes, ma'am.
If Dr. Sangeeta Jogi ma'am is ready, otherwise we have to go to her.
Yeah, ma'am, I'm ready.
Yes, yes, yeah.
Yes, ma'am, you can start. I had already asked them, but still.
I don't understand that. Shall I start?
Okay, let us introduce Dr. Sangeeta. You can start your presentation then.
The screen?
Screen is seen?
Yeah, yeah, it is seen.
Yes, yes, it is seen.
Good evening, everyone. I am audible, right?
Yes,
Yeah,
you are
you
right.
are.
So thank you, Dr. Lakshmi and Dr. Richa madam for giving me this opportunity. I am going to speak on challenging cases and lesson learned. So we have 4 cases. One by one, I will discuss. So the case 1, a 35-year-old patient was admitted at Bilaspur on 20th April. She is a case of pregnancy 15 weeks with history of previous 2 LSCS. And her chief complaints were pain in abdomen, radiating to back and thigh since 2 days.
Vomiting off and on since 2 days. Her LMP was 5th January. UPT was positive. She gave history of self-abortifacient intake from a medical store without consultation of a doctor. She was gravida 3, para 1, live 1, abortion 1. For their abortion history, she had again a history of self-abortifacient intake 1 year back at a amenorrhea of 2.5 months, followed by DNC at private nursing home. At present, she is gravida 3. On examination, patient general condition on admission was very poor. Pulse 140 beats per minute. BP was 80/50, marked degree of pallor present. On systemic examination, respiratory rate 28 beats per minute. CVS normal. Per abdomen, marked gardening, distension, uterine contour cannot be made out because of that. PSPV examination was close, active bleeding present. So the provisional diagnosis of uterine rupture was made. All investigation, all base blood investigation sent. Hemoglobin was 6.4%. Platelet was 1.2 lakh. Liver and renal function was normal. Obstetric sonography suggestive of non-viable fetus, 15 weeks in the left side of the abdominal cavity with uterine rupture of approximate 4 into 3.2 centimeter in size. So the management, we have taken high-risk consent. Patient was immediately shifted to OT for emergency exploratory laparotomy with blood under GA on 20th the same day. So intraoperatively, we find massive hemoperitoneum, uterine rupture, attempt to meet and repair the rupture site, but it's not possible because it's bleeding and uterus is not contracting that time. So obstetric hysterectomy was done. After taking consent, abdominal drain was kept in situ. Patient shifted to ICU for monitoring, and she was exhibited on POD day 2. Post-operative, 1 whole blood, 2 RBC packed, and 4 FFP were transfused, and she was stable and discharged on day 7. This was the specimen of that obstetric hysterectomy. So what was the challenge? It is always challenging to treat a case of near miss. Though this case looks simple to diagnose and manage at our tertiary center, but it may be challenging to manage it at many other centers and sub-centers and diagnose it properly and proper time. In our challenge, and the main challenge was timely arrangement of blood and blood products as per massive transfusion protocol is needed to save this patient. So the lesson learned are, any young patient who is pregnant with severe abdominal pain should be considered for obstetric emergency as ruptured ectopic or ruptured uterus unless proved otherwise. OTC abortifacient, which are available on the counter, is a risk factor for ruptured uterus and scarred uterus. We all encountered these cases. So multidisciplinary team approach, timely diagnosis, prompt intervention, excellent ICU care, and availability of blood and blood products help in appropriate management of such high-risk cases. So this is case 1. Moving to case 2, a 24-year-old female with previous 2 LACs with 6 weeks of pregnancy admitted again in our institute. Her chief complaints were self-intake of abortifacient at 6 weeks of pregnancy, followed by DNE 20 days back at a private center in view of incomplete abortion. Now she is complaining of spotting PV since 20 days, mild abdominal pain, which is radiating to back since 1 day. Her LMP was 1st January 2023. She is para 2, live birth 2, abortion 1, with previous 2 LACs, both alive and healthy. Last childbirth was 6 months back. On examination, her vitals are stable, pulse was 96, BP 120/68, mild pallor was present, respiratory rate and CVS is normal, per abdomen is soft, mild tenderness was there in the lower abdomen. On PS, spotting present, cervix and vagina grossly looked healthy. On PV examination, uterus anteverted 8 to 10 week size with mild cervical tenderness present. So all the baseline investigations sent, UPT positive, hemoglobin was 9.8, platelet is 1.08 lakhs, renal and liver function normal, thyroid profile normal. Obstetric sonography suggestive of enlarged uterus with intrauterine heterogeneous cystic collection seen approximately 2 into 3 centimeter with bilateral enlarged hyperstimulated ovaries present, and there is thinning of scar at the scar side, which is 3 millimeter. So because of presence of this picture of hyperstimulated ovaries, we found the sonography, then we go for X-ray chest, which is normal. So provisional diagnosis of persistent trophoblastic disease was made. For the management, high-risk counseling done regarding both conservative, methotrexate or surgical options. Patient opted for medical management because her WHO prognostic score was 5. Total injection of methotrexate 4 with folinic acid was given, but there is a rising titer of beta HCG instead of fall. So repeat sonography was done. It was shown that previously it is 2.3 centimeter. Now the cystic collection was increased to 4 into 3 centimeter, and the thinning of the scar is now 1.5 centimeter seen. Again, high-risk counseling was done about PTD and risk of scar rupture, available conservative options and need of hysterectomy. Decision was made to perform hysterectomy after taking informed consent. So hysterectomy was done. Post-operative period uneventful, discharge on day 7. Her histopathological report suggestive of PTD. WHO prognostic score done and the chemoprophylaxis was given. This was the specimen of this patient. So what was the challenge? In this case, the main challenge was uncertainty of diagnosis because that time our MRI was not working and dilemma and decision regarding its medical or surgical management was there. So MRI helps, the lesson learned are MRI help to make an accurate and proper timely diagnosis. WHO prognostic risk scoring should be done in all molar pregnancy and chemotherapy should be considered. Patient surveillance and serial beta HCG during entire course of treatment is crucial in cases of gestational trophoblastic diseases. Coming to case 3, a 36-year-old patient come in our department on 17th February with 6 weeks pregnancy with previous 2 scar, with complaints of abdominal pain radiating to back since 1 day. Her LMP was 3rd January 2023. Her obstetric score are Gravida 3, Para 2, Live Birth 2. First child was 12-year male delivered by cesarean section. Second is 9-year delivered by cesarean section. No past personal or medical history, any significance. On examination, general condition average. Patient was oriented to time, place, and person. Her vitals were normal. Pulse rate was 100. BP was 110 by 80. Mild pallor was present. On systemic examination, CVS-RS normal. Per abdomen, soft transverse scar present. Abdomen is soft and there is transverse scar present. PV examination was closed. There is no active bleeding. We do hemoglobin, which is 10 gram per cent. Platelet is 2.5 lakhs. Renal and liver function normal. Thyroid profile normal. Beta HCG was 4,000 on 17th April. And sonography suggestive of scar, cesarean scar pregnancy with gestational sac and yolk sac at the site of cesarean section, and the overlying myometrium thickness of 3 millimeter. MRI done suggestive of cesarean scar pregnancy. So the provisional diagnosis of cesarean scar pregnancy was made. For the management, patient admitted and counseled. Counseling done, high-risk consent taken for conservative management. Intrasec methotrexate injection was given under USC guidance. The post-procedure patient stable at discharge. After 1 week, beta HCG was 2000. This is gestational sac before procedure. And this is after procedure, the gestational sac was shrinken. So the challenge, what we faced are, if there is absence of radiologist, which is experienced to diagnose and inject methotrexate, it's a challenge for us. but luckily we have that facility. But second one is in cesarean scar pregnancy. If we do DNC directly, it may lead to life-threatening complication. So the lesson learned, all the patient must undergo sonography obstetrics in first trimester. MRI should be done in selected cases to confirm the diagnosis. In cases of scar ectopic, conservative management like with intrasec methotrexate is ideal. In ectopic scar pregnancy, DNC may lead to life-threatening condition, as I told you. That leads to obstetric hysterectomy. In such cases, hysteroscopic guided DNC should be a better option. Coming to our last case, a 35-year-old patient was admitted in SIMS Bilaspur on 1st February with 8 weeks pregnancy with incomplete abortion. Her chief complaints were bleeding PV off and on since 10 days, and her LMP was 7th December 2022. She is Gravida 3, Para 2, Live Birth 2. First child is 5-year-old girl, normal vaginal delivery. Second, 2-year-old male child, full-term normal vaginal delivery. On admission, patient general condition is very poor. Patient was drowsy, responding to verbal command on pain and stimuli. Though her vitals are, pulse rate is 140 beats per minute, BP is 70/30, PLR 4+. On systemic examination, respiratory rate is 30 per minute, SNS to normal, abdomen is soft, and presence of clot in the vagina. Baseline investigation, hemoglobin 4.8 gram, platelet 1.4 lakhs. Rest, everything is normal. She had her sonography with her. That was incomplete abortion. So the provisional diagnosis of incomplete abortion made. For the management with high-risk consent, she was shifted to OT after stabilization with blood in hand. On minimal cervical manipulation, patient started profuse bleeding. So the consultant on duty called the senior gynecologist for help. On PSPV examination, a senior found that the cervix is ballooned up with mild active bleeding. So the diagnosis of cervical pregnancy was made clinically. Balloon tamponade along with cervical stitch at 3 and 9 o'clock position taken to stop the bleeding, but it continued to bleed. So the decision of laparotomy was taken, and that is done after taking consent of the relatives. So intraoperatively, uterus mildly enlarged, cervix ballooned up, and obstetric hysterectomy was done. Blood and blood products were transfused. She was shifted to ICU and discharged on POD 10th.
Madam, I think we are running out of time. Please wind up, madam.
The last one, HPV, cervix enlarged, highly vascular, cervical ectopic invasion of cervical muscular is present. This was the specimen. You can very well appreciate uterus is small and this all the cervix is ballooned up. So final diagnosis of cervical pregnancy was made. The challenge, it was a challenging situation for us as the patient arrived in shock. So we have to promptly diagnose and treat this patient to save her life. Lesson learned are very important. In this case, we thought that it is a case of incomplete abortion for which the patient was taken for DNC and she landed up in profuse bleeding for which obstetric hysterectomy was done. So we, the clinician, should have vigilant and high degree of suspicion for abnormal pregnancy. Pelvic examination is must in all the cases. Don't hesitate to call the seniors in such situations. This is the management option we have already discussed yesterday, so I'm skipping this. So take home messages. Pelvic examination is must in all the cases, so we won't miss any important finding which are helpful in making accurate diagnosis. High degree of suspicion required while dealing with obstetric emergencies for early identification and prompt management of these cases. All patients should be properly counseled and follow up. All women should have aware of safe abortion services so that the life-threatening complication can be prevented. Availability of assured referral system must be there. Availability of ICU specialists, blood and blood product at referral center. And the most important, implementation of law to prohibit supply of over-the-counter abortifacient drugs. Thank you very much for the patient listening. Thank you.
Thank you, madam.
Very nice presentation, Dr. Sangeeta. You had really highlighted what were the problems and what were the lessons learned. It was nice presentation, and even Dr. Roma also had presented very well how to go about working up a case of rape victim. Dr. Roma, if you are there, there are a few questions. Just kindly answer in the chat box. Okay, so Dr. Sati, are you ready?
Can you see my screen, ma'am?
Yes, we can see your screen. Please put it on the. Yeah, it's a PDF sort of. I think you have to put in the other mode. The slide share.
Slide share.
You can just present like that, Dr. Satya.
Okay, okay.
We are running short of time now, so you just quickly just present like that.
Good evening. My topic for today is biomedical waste management. Biomedical waste management is really important for the current trend because we are responsible for the environment and for the healthcare workers who are handling biomedical waste management. So what does biomedical waste mean? They are the waste which are generated in the hospital during the diagnosis, treatment, or immunization of human beings or animals at research activities. These are called as biomedical waste. And there are healthcare waste such as byproduct of healthcare, which include sharps, non-sharps, blood, body parts, chemicals, pharmaceuticals, and medical devices and radioactive materials. Sources of biomedical waste are got from hospitals, nursing homes, clinics, medical labs, animal labs, and blood banks. These are generated at home if there are people who are ill at home and they are using some medicines and all, like dressing material, injections at home. They also can provide biomedical waste. The need for today's biomedical waste management is because we have to provide a safety environment and for the healthcare workers who handle all these items. So the types of waste are like 3-4 types: human, animal waste, and soiled waste. These are endangering the environment because of the risk of HIV, HBV, HCV, hemorrhagic fevers, cholera, salmonellosis, lepto, and all. Sharps also can provide cross infection like HIV, special HIV, HBV, and HCV. Cytotoxic radioactive waste can provide birth defects for the next generation. Chemical waste can cause poisonings, dermatitis, conjunctivitis, and bronchitis. So today's need for biomedical waste management, the drugs which are disposed should be usually what they are doing is they are disposed of and repacked and sold to other buyers, unethical people. Then the risk of air, water, and soil pollution. Then the risk of infection outside hospital for those handlers, for the scavengers and all. So there are certain rules which were came into enforcement in 1998, and amendments came in 2000, 2003, and 2016. So these rules apply to all hospitals who generate, segregate, collect, receive, store, transport, and treat, dispose biomedical waste in any form. So what are the steps? In short, are characterization of the biomedical waste, generation of the biomedical waste, segregation, collection, storage, transportation, and treatment, and disposal is the final step. So according to WHO, most of the biomedical waste is it's from the hospital, which is 85%. Most of them are hazardous. Non-hazardous is 10%, and 5% is non-infectious. What are the characteristics? There are two types: hazardous waste and non-hazardous waste. Hazardous waste poses a substantial threat to the environment. Non-hazardous are those solid waste which are not, which do not provide a significant threat to the environment. So the type of waste can be described like this. What comes under non-hazardous waste are from the office, kitchen, admin, hostels, stores, restrooms, and from the municipal and public authority. And the hazardous are from our hospital wards, treatment rooms, dressing room, OT ICU, labor room, laboratory, dialysis room, CT, and radio imaging. So next step is segregation. It should be segregated at every area. They should be provided with color bins. So the color bins and color bags to match it. So the segregation protocol is fixed. It has yellow, red, white, and blue. So yellow, what type of biomedical waste should be disposed are human waste, animal waste, soil waste like gauze pieces, swabs, diapers, sanitary napkins, mask, expired medicine, chemical waste which contain body fluid, and clinical waste. So red is basically for contaminated waste. So it is recyclable like plastic bags, bottles, catheter, rubber tubing, plastic syringes. White is for scalpels, for sharps. Blue is for broken glassware or metallic body implants. The anatomical waste, all what we deal with, placenta and products of conception, amputated parts, bone fragments and all, it should be put inside the yellow bin. And the segregation should be perfectly done and handled very carefully. And solid waste is like all these as shown in the picture, the IV cannula, catheters and all in the red bin, as I told you. And the non-biodegradable waste are like broken, discarded and contaminated glass syringes or any vials. It should be disposed carefully in the blue bin. Sharp waste, they should have a separate white color sharps bin for this. And it should be disposed very carefully because the prick injuries are very common in this. So the general waste like these canteen waste, paper covers, plastic covers and all, vegetable waste, food waste should be put in the green bins. The collection is done usually by the sanitation staffs, which they should wear proper gloves, which is till the elbow, and they should wear proper covering for themselves while shifting and collecting the waste and disposing it. And the nursing supervisor or sanitation supervisor also play an important role in segregation of the waste and disposing it. Next is the storage. Storage should be carried in those plastic covers first, and it should be neatly sealed. And you should not store it for more than 48 hours. And the transport should be done in wheeled containers because manually carrying it is not feasible and it is dangerous for the scavengers. They should be easy to load and unload. And no sharp items should be in all these covered bins. So the treatment and disposal is initially the animal parts, the products of conception, which should be dumped at the municipal dumping site. They should undergo treatment first. So the sanitation supervisor should be responsible for the coordination between the municipality and the hospital. So there are certain labels which help in differentiating all the types of waste. So this symbol which is in the left side, it indicates biohazard, and the symbol which is in the right side indicates which is cytotoxic waste. So the treatments to be done prior to disposal. So the yellow bin, as what I told, products of conception, anatomical waste and solid waste and all should undergo incineration or plasmapyrolysis. It should be pre-treated before mixing with other waste water. The red bin, it should be carefully autoclaved or even hydroclaved, and it should be recycled, but not to the landfill. White, the scalpels, blades, needles, and lancets should undergo autoclaving, dry heat sterilization, followed by shredding or mutilation before disposal. So what are the action points are? You must always pre-treat the laboratory microbiological waste, products of conception, and blood samples before even disposal to ensure no one is affected in future. And you must provide training to all the healthcare workers, including scavengers also, sanitation workers. Immunize all the healthcare workers regularly. And hepatitis B and TT should be provided in all hospital setups. Establish a barcode system for all the bags and containers containing the biomedical waste. Action points are ensure segregation properly, provide proper protection equipments for the collection and disposal, health checkup for all the scavengers, sanitary workers every year, and all these waste should not be held for more than 48 hours. In our hospital, they regularly have a biomedical waste management audit, and these are the forms. In these forms, they go checking. There's a team which goes checking whether the bins are safe, whether their covers are placed properly, and the sodium hypochlorite is provided in each ward. How do they autoclave? All this is ticked in these forms. And so these forms accordingly So the audit happens every month. And so this is maintained in our hospital. So the take-home messages are never fill the sacks more than 3/4 full. Overfills can even spill outside, and sharps also by mistake, if they put in, can prick other people. Do not use anything which leaks. Secure sacks with a plastic tie. And if it's a special waste, you must label it properly and avoid keeping it for more than 48 hours. Thank you. Thank you, ma'am.
Thank you, Rakshatya, for the very informative lecture and something we all need to know and keep ourselves and others safe. Thank you very much.
Thank you.
Okay, so now we finished our scientific session. Now we go on to our post-test. So Nilima, can you share the link in the chat box? Are you there, Nilima?
Ignace is there. I have told you.
They have posted.
Ma'am, I
Okay,
have
so the
shared.
link. Yeah, thank you. So the link has been shared in the chat box. So you'll get 10 minutes. Okay, so we start the timer.
Hello. Hello. Yeah, who's speaking? Yes, hello. Yeah, I'm in a meeting. Tell me. Yeah.
Mute yourself, Anuradha, mute yourself. So last 40 seconds left. Okay, so time is up now. Okay, so now Dr. Anuradha, can you share your screen and tell the answers?
Yes, yes. We go to the answers. The first question, answer is 1D. Second question, 2B.
You read the answer also, Dr. Anuradha. What is the answer? Full answer. Yeah.
Acha, read the full answer. Okay.
Okay, second one.
The second one is B. Third one, one second. Yeah. Third one, minor means age is less than 18 years. 3D. Under provision of POSCO Act 4, the answer is D, any of the above, the parent, person who trusts, or a woman. Then fifth, then answer is D, that is less than 18 years of age. Sixth, the answer is A, that is 164A. Seventh, any registered medical practitioner, that is C. Question number 8, answer is D, that is none of the above. For everything we need a consent. 9. The answer is C, 12 years. Question 10, answer is B, second examination letter date. And the 11, it should be collected within 72 hours. The answer is C. For question number 12, the answer is B, no. For question number 13, answer is B, that this has to be taken from posterior part of the buccal cavity. 14, the question is D, yellow bin. Question 15, the answer is C, section 312. Section C 16, the answer is D, form A plus B. Question 17, answer is C, that's form 3 has to be filled. Question number 18, the answer is A, consent form. Question number 19, the answer is C, imprisonment for minimum of 2 years. Question 20, answer is A, penalty up to 1,000 rupees. Question 21, the answer is B, termination of pregnancy at 24 weeks in case of contraceptive failure. We cannot be doing that. Then question number 22, the answer is A, punishment for feticide is 3 years. Question number 23, answer is A, Pre-Contraction and Prenatal Diagnostic Technique Act. Sorry. Preconception and Prenatal Diagnostic Act. I mean, the A is little spelling mistake. 24, the answer is B, section 18 and 19. 25, the answer is D, 2 years. 26, the answer is C, 5 years. 27, the answer is A, yes. 28, the answer is D, all the above. 29, it is B, false. 30, answer is C, 2. I think we have come to the end. Richa madam, please.
Okay, so now we have come to the end. So now thank you all the delegates, all the participants for joining this course, and we hope that it was very fruitful for you all. And thanks to all the faculty, chairpersons, speakers and experts for taking out the time and giving the informative deliberations. So, and thank you coordinators, Dr. Anuradha, you have done a very good job, and Dr. Roma also, and then Dr. Kruti Deriwala also, you all have coordinated very well. And thanks once again to ICOG and Dr. Lakshmi Srikhande madam for giving our MTP committee this opportunity to conduct the online certificate course. So once again, thank you everybody. So certificates now, who have all the participants who have given the post test of all the 3 days and they have secured more than 50% marks. So the certificates will be mailed to you within 1 month.
And
so
thank you, Richa madam, for this 3 days long academic extravaganza. I think all of them enjoyed like us. And we should
thank you. Thank you everybody, and good night.
Bye. Bye.